Wanted to welcome you to today's conference. I'm Brittany Ritchie, for those of you who haven't met me before, virtually or in person. Work here in the Research Institute at Seattle Children's, and so we're very pleased to once again be hosting today's fair in partnership with the Born a Hero Research Foundation. I believe this is our third time hosting this event as the virtual in-kind host, and we choose to partner with Carolina Summer, who many of you know and we'll hear from in a moment, since her passion aligns so much with our mission to help kids live healthier lives. In fact, by nature of the fact that they affect children, most pediatric diseases are rare diseases in the population count. FGFR syndrome being no exception. So for those of you who don't know us, I know we've got folks from all over the world today. I wanted to let you know a little bit about who we are. Seattle Children's has been a part of the Seattle community since 1907, providing care to children regardless of their ability to pay, their economic status, their race, their sex, anything like that. So we're very, from the very beginning, have just strived to include, just take care of all the children in our community, in our region. Our research division specifically is about 17 years old and is closely tied with the hospital, Seattle Children's Hospital. Both of them are supported by our amazing foundation and the community in the Northwest and around the country. Together, we all work towards our ultimate mission to provide hope, care, and cures to help every child live the healthiest and most fulfilling life possible. At the research division, that means studying and supporting and leading research in all types of areas, from the impact of media use on children's development to groundbreaking cancer immunotherapy program that we have, to our dozens of projects related to SARS-CoV-2, COVID-19, of course, rare diseases like FGFR syndromes. So we're super proud to be part of today's event once again, and you all are putting your heads together to move in the same direction that we are to help kids live healthier lives by advancing research in basic science and therapeutics. So without further ado, I will turn it over to Carolina.
So good morning, dear friends and colleagues. I welcome you to a collaborative space where we come together to forge connections and drive positive change. I just want to start actually by extending my sincere gratitude to Brittany and Amy. Your hard work and kindness in organizing this event has been nothing short of exceptional. Working alongside such organized and wonderful individuals makes me feel just so incredibly fortunate. So thank you. For those who may not know me, I'm Carolina Summer again, the CEO and founder of Born a Hero Research Foundation and the co-founder of the Northwest Rare Disease Coalition, where we pass and advocate for bills both on a state and federal levels, and are passionate about complex care coordination, cell and gene therapy, and genetic testing education. My journey into this realm began as a mother to a rare disease patient and my personal hero, Mariana. It's this journey that fuels my commitment to the rare disease community, a community that embodies tears and hurt and helplessness, but also exudes fire and courage and joy, success, and an unwavering fight for happiness and hope. Meeting these families and hearing their story just changes you. It shapes your perspective entirely on life. Thank you all for being here today in this meaningful occasion. As we reflect on our collective journey, we've witnessed remarkable progress in rare disease care. Gone are the days of dire circumstances, limited resources, fewer options, and more complications. Today, we can celebrate the achievements of multidisciplinary teams, fewer surgeries, better treatment outcomes, and improved syndrome diagnoses. Each of you has played a crucial role in the advancements, and for that, I just want to say that I'm genuinely proud of you guys. But as we bask in this excitement of scientific breakthroughs with AI, whole genome sequencing, and cell and gene therapy, we must ask ourselves, how do we keep up with this fast-moving world of scientific innovation and ensure that patients have access to these breakthroughs? So I believe at least that one answer lies in collaboration and education. Our journey together has transformed rare disease care, yet there are gaps that really need our attention. For instance, there's a study in North Carolina revealed that 90 to 99% of physicians surveyed didn't even know how to refer a patient to a genetic counselor or to interpret the test, which is a pivotal role in genetic testing and diagnoses. The gaps in education and care coordination contribute to this diagnostic odyssey that is now lasting 6 to 9 years. And just, are we listening to these obvious gaps in the system, right? We explore how creating collaborative research networks, partnering with institutions and legislators, keeping collaboration at the center of our efforts, amplifying the patient voice, and supporting families, and how this just drives success in rare disease care, research, and innovation. So I'll start with the first one, which is Collaborative Research Network. Creating spaces like today isn't just important, it's vital, a place where basic, translational, clinical scientists team up with the patient voice. It's a space for constructive conversations, feedback, and collective progress. What's on the other side? Assumptions, judgment, fear, and not seeing the bigger picture, like what's best for the patients, and why am I doing this? What is success? It's crucial to be aware and recognize these barriers that push us away from collaboration. So Dr. Fajgenbaum, who faced his own life-threatening disease, was the one that introduced this idea of collaborative research network. Urgency compelled him to collaborate swiftly and cure his own rare disease. And today, his AI-driven approach, backed by the Chain Zuckerberg Initiative, is repurposing drugs for other rare diseases. But do we need to wait until this point where we feel helplessness to collaborate? Today, at this Collaborative Research Network conference, we're exploring how therapies for other rare diseases can be harnessed to aid our community. We need to think outside the box. And so it doesn't have to be this like grandiose idea. Sometimes just the smallest, simplest things are just what moves mountains. So 2, collaboration with institutions and legislators. So beyond the FGFR space, we're part of a larger community, the craniofacial and rare disease community, where we encounter similar barriers and challenges. Collaboration with institutions, researchers, pharma, biotech, legislators, patients, and payers, insurance companies is crucial. Legislative action can be a game changer. A click to supporting causes like NIH funding, genetic counseling reimbursement, Medicaid, whole genome sequencing, and others, out-of-state care and others can collectively make a significant impact. Guys, like I just want to say like rare disease patients are the experts in navigating the healthcare system. They know the gaps and the loopholes. In 2019, our Relife Foundation revealed the economic burden for rare diseases was over $966 billion. Yes, collaboratively, we're enormous. But legislatively, this means that we have the power not only to help rare diseases, but to help change the healthcare system. Organizations like ours, the Northwest Rare Disease Coalition and Every Life Foundation, can help you get involved in this and initiate these conversations with legislators and other stakeholder groups. When I can bring together pharma and an institution to talk and realize that they want the same things, my heart just wants to burst. And when I'm able to explain to a legislator why we need pharma at the table and change their hearts, those moments give me hope. So number 3, collaboration will make you more successful. Collaboration is an investment. You give in some to gain a whole lot. It's akin to the principle of investing in money to make money, right? Efficiency multiplies when we work together, aligning all stakeholders at the crossroads of progress. There is always a place where we can meet each other, I promise you. Consider the success story in cancer research. I attended the Northwest Association for Biomedical Research Gala. I had the chance to talk to the surgeon being recognized and awarded for this remarkable award in the cancer world. He created a collaborative platform, much like our research registry, involving centers from all over the world, with surgeons and scientists inputting data. I asked him, like, how the heck were you able to get all the centers to collaborate? And he chuckled and said, when I made them realize that there was a big problem. The results have been tremendous, from a high mortality rate of 1 in 10 people undergoing a particular surgery to improved surgical outcomes, among other benefits. Before, everyone was doing great work individually, yet a significant number of people still faced fatal outcomes. And together, everyone benefited from the registry. Most importantly, treatment improved for patients, and it happened faster. And so how does it work? Potential research studies are submitted, viewed, evaluated, and the necessary data from the database is shared if it's the rightful fit. So it seems like a simple and self-explanatory model that we hope to follow with our FGFR research registry. And we just hope that you can all get involved. So think about this. What happens to the data when someone in an institution or a company retires? Like, we just have no time for this, and time is of essence for our rare disease families. And we can all benefit from the registry. We have a fast IRB approval, like a week, simple consent, and we want a partnership with you and share data. Ellen will go more into details about the registry shortly, so I won't get into that. So speaking of collaboration, we also will hear today about barriers faced in other countries, like what can we learn and how can we help? So I know that everyone's really busy and that's part of the problem, right? But one can only do so much, right? But that's why we need each other. We have volunteers, we can help, we have voices and connections. Number 4, patient voice at the center of innovation and research. So let's talk about patients as more than just subjects. Incorporating their voices in research can make endeavors more efficient. The patient voice makes science and innovation efficient. For example, you might be noticing things with the mouse model that would all make sense and significantly ease research if you knew about the symptoms that patient was experiencing. And guess what? Patients are willing to contribute. You just need to ask. So that goes with my 5th point, which is supporting families. So patients do want to get involved, but especially when they understand the ongoing scientific efforts. Right now, families don't know about these amazing science that's going on. Collaborate with patient organizations to demystify sort of the scientific world for families. Navigating the internet can be daunting and an incomplete experience for us. Help our patients trust in science and instill hope with this exciting new treatments and therapies that are in the horizon. But keep in mind that support beyond surgeries is crucial for families facing medical trauma. Let's make the journey about more than just treatments and surgeries. The UK has been a leader in mental health for our families. We will hear from Dr. Rosanna Samuel shortly on their model, which I just absolutely love. We have so much to learn from each other, but patient organizations also just have so many resources to offer our families. Born a Hero, CCA, Smile Train, the ARC, Courageous Parent Network, the Center for Chronic Illness, Teleplay, just to name a few. So in closing, I'd like to share a personal story, a glimpse into the challenges and triumphs that underscore the urgency and importance of our shared mission. Better patient outcomes, better patient access, patient-centered care, and collaboration for efficiency in a fast-growing world of patients and science. So Mariana spent the first 6 years of her life going to the hospital approximately 6 times a month. What did that feel like? Every time Mariana went into surgery, my husband and I felt like throwing up. There were times where where she was lethargic and I couldn't breathe, like my heart just wasn't strong enough. I remember moments where she was held down for procedures, screaming like I couldn't even watch. So many times I held Mariana tight, afraid I might lose her. I just laid next to her crying quietly so she wouldn't notice, trying to be strong. Now I just hold my family tight because I'm not able to take any day for granted. Life is just too fragile, and I'm reminded often a parent has to leave their job to care for their child 24/7. Imagine spending hours a day feeding your child, and there's a shortage of nurses. So often parents take shifts to stay up watching their kids all night because they have a trach. There's a bill coming that will really benefit these families. So excited for it. The goal is that caregivers who care for these very complex kiddos will be paid, especially when there's just such a shortage of nurses. So for 11 years that Mariana has been on Earth, she has had 11 surgeries, most of which have been brain surgeries. I have had health issues since she was born, and I see the same pattern with other rare disease moms. Our bodies just become so consumed by stress that we have chronic pain, develop autoimmune diseases, heart conditions, fatigue. Our bodies just kind of give up on us. And as you can see, rare diseases affects just entire families, not just the patients. On a positive side, Mariana is thriving and has become this beautiful young woman with a heart full of love and understanding for people. She's had the power to transform those around her, making them more compassionate just with her grace. Due to all the bullying she has received, she has learned a lot about being a peacemaker. The other day, Mariana's friend was arguing with another little girl, and Mariana said to her friend, "You have to be the first person to apologize. Change has to start with you, even if you're wrong." Her friend looked at her, "You sound like a fortune cookie." And she's totally right. We have to be collaborators, meet people where they're at, be the change we want to see, not wait. Getting to know the families and collaborating with the patient organizations is your inspiration. If we do our part and work together, we can be that change together. This is a slide that I just wanted to share with you because I love having something that that you remember why you are here. Now I'd like to introduce you my dear friend and colleague, who I absolutely just love working with, Ellen Morgan, founder of the 501c3 nonprofit PROS Foundation. She has had over 25 years of drug development experience in various sectors, including large pharma, small biotech, and CRO. Her expertise extends to leading successful clinical research organizations such as Synteract and Agility Clinical. Previously serving as president of Rare Diseases at Precision for Medicine, Ellen is dedicated to accelerating effective treatments for rare diseases through PROS Foundation. She holds a BS in chemistry and an MS in management and industrial engineering from, I'm going to say this wrong, Rensselaer Polytech. Right? Did I say that?
Even say it.
Okay. Thank you, Ellen.
You know, I think Carolina's personal story and those of other parents like her is the reason we're all here today, I think. I am very excited to share that after a couple of years of work that we launched the FGFR Syndromes Patient Registry last September. So first of all, what's a patient registry and what's a natural history? So a lot of times we hear those two terms used interchangeably, and they are a little bit different. And we refer to the FGFR platform as being a registry, but in reality, it's actually a natural history study. So a patient registry is a collection of standardized disease-related data about a group of patients who have a condition, and it's typically a one-time data collection. Natural history studies, on the other hand, track patient data and experiences over time by identifying things such as demographics, environmental conditions, and genetic variables that correlate to the disease. We learn about the symptoms and most importantly, disease progression and outcomes. And it produces a much greater understanding of how the condition develops and how it can be treated. So the registry, as I mentioned, what we call the registry for FGFR syndromes is truly a natural history study because we will be collecting data over time. Carolina touched on this, but why do we need a patient registry? There's a lot of data available for common diseases like diabetes, for example, but for rare diseases, there's very little data about them. And it makes it difficult for researchers to actually develop a treatment or know how to treat it without having more data. I've seen many examples of rare disease clinical trials where there was no data and the trial was designed incorrectly and failed. So we don't want that to happen. So the FGFR Syndromes Patient Registry, as I mentioned, was launched in September, and we're using the NORD IAM Rare platform. So NORD is the National Organization for Rare Diseases, and they have 40 years of experience in patient advocacy. And they've also included input from doctors, researchers, and the FDA in developing the platform. So the primary goals of the registry, number one is to understand the relationship of genotypes for FGFR syndromes with phenotypes. As you know, the genotype is the genetic information that determines an organism, and the phenotype is the observable physical traits. This data will help researchers in the development of treatments. The syndromes being studied in this registry are caused by variations in 3 genes, FGFR1, FGFR2, and FGFR3. So basically, we want to figure out which variants in which genes result in which traits. And this is a list of the 15 syndromes that are included in the registry currently. And the ones certainly that you've heard of are Pfeiffer syndrome, Cruzon syndrome, Apert syndrome, and there are a lot of them that are actually even more rare, even though each one is considered rare. So other goals of the registry include characterizing the population as a whole, understanding the disease prevalence, the rate of progression, and signs and symptoms over time. Another goal is to help physicians study approaches and outcomes for rare problems across institutions. So, a physician at one institution may benefit from their personal experience or experience from others at their hospital, but having the registry, they might be learning from other institutions as well. And then it's also a resource for clinical researchers to help them design prospective trials of novel treatments and to serve as a control group in a clinical trial. So I think you'll hear more about how useful natural history studies can be to clinical researchers a little bit later today. So how does a registry help them? It helps them define the study endpoints. Basically, what effect should we measure? What symptoms and conditions are most important to patients? How can we actually impact those symptoms? That helps them understand how the disease changes over time. How are the symptoms expected to improve or worsen? And how can we measure effect? In this example, it may be reducing the number of surgeries that are required for a patient. So that's something that we're capturing data on. And to define the patient population, who are the candidates for an experimental treatment? Who can we treat? And then when there is a clinical trial, it's certainly helpful to know the patients that might be able to participate in the trial. And then lastly, additional goals are to really increase the appreciation of the social and emotional and financial stresses for patient families. So we can provide better support and to develop contact registry. So I'd like to tell you a little bit more about the actual data that we're collecting and how we're using it. So first of all, before any data can be collected, there's a consent form that needs to be read and executed. And the consent form explains the goals of the registry, other information about it, where the data is stored, how privacy is protected, how the data will be used. As I think Carolina mentioned, the registry has oversight from an investigational review board called North Star. So then once the patient or the parent consents, they can actually request help with genetic testing, and we at Born a Hero will help obtain that. So this is a list of the key surveys that we're collecting. So demographics, diagnosis, medical history, research history, disease-related conditions and treatments, and this is the big one really. Additional disease-related information and genetic and clinical diagnosis reports. So we are actually asking for these reports to be uploaded so that we can actually at some point down the road have a geneticist or a genetic counselor take a look at these, and that will help with the primary goal of relating the genotype to the phenotype. Most of these surveys are pretty quick to complete, so it doesn't take that much time. And you can actually, if you need to stop to get more information, you can save your progress to date and then move on. And then in the future, we're planning to add quality of life surveys and cost data. And we think this will be helpful down the road when there is a drug to be marketed on justifying the cost. And soon we're going to be adding language translations, and we're starting with Spanish. So we'll be adding that shortly. So a little bit more on the disease-related conditions, since this is really the meat of the registry. So we're collecting data about conditions that the patient may have in a number of these different areas: bone and muscle, face and jaw, skull, neurological, quite a few things here. And then for each section, we're asking for more details, which would include the approximate age when this was first noted, the form of treatment, was there a surgery, medication, physical or occupational or educational therapy, was there a medical device used, the number of surgeries for the condition, and a little bit of information about the surgeries. When did the patient have the treatment? Were there any complications? And kind of a free text form. Would you do anything differently? Okay. So another great feature of the registry is visuals that the person who's entering the data can actually see. So this is an example that's in the registry that, when you're looking at data, you can see that. So based on the data we have so far, we see that the participants were diagnosed. 64% of them were under the age of 1. 21% were over the age of 1, and 14% were diagnosed in utero. And another type of visual that we have is information about each of the conditions. So this one shows a bar chart of the skull and neurological conditions, and we can see that 85% of the participants actually had Chiari malformation, 60% hydrocephalus, and then a number of other things are listed here. The total number of procedures, and this one really bowled me over, that participants have had. So 43% have had over 20, and 29% 5 to 9, 21% 10 to 14. Pretty amazing. In addition, the data can be exported. So this is something that can be useful to researchers. And this is just a really simple example of a post hoc analysis. This shows the number of participants who experienced shunt failure, the time after surgery that the shunt failure occurred was in the first month. And the number of shunt revisions. So the mean number was 10, and the maximum was 20. So it's pretty interesting information. So one of the things that often gets overlooked is the mental health issues that patients experience. So we are collecting some data about mental health, and this is an example that shows that 35% of the patients have anxiety related to their surgery. 35% actually had none, but we need to understand that some of these are very young. Some of these patients are quite young. And 12% experienced depression, 5.9% with memory loss. It's pretty sad. Carolina and I would like to thank our Registry Advisory Board members. They've really helped us determine what data to collect, and helped with the testing and the refinement of the registry. We'd like to thank Dr. Amy Merrill, who is at University of Southern California, Dr. Dahl, who is a professor at the University of Washington, and in the medical director at Seattle Children's Hospital, Dr. Farron, who's a pediatric plastic surgeon and director of the Craniofacial Center at Children's Medical Center in Dallas, and Dr. Ken Nishal, who's the chief of the Division of Ophthalmology at Children's Hospital of Pittsburgh. So we have some data, as you could see, and we've learned a little bit about the data so far. But the more participants we have, really, the more useful the data will be to everyone. So we urge you, if you have a child with an FGFR syndrome, or you know someone, or you're treating patients, please participate or refer patients to the registry. We are reaching out to organizations across the globe to refer patients to the registry. We are now partnering with Indo-US Rare in India, and attending conferences in Africa. So as we gain data across different geographies and different races, it will really help us understand the data even better. So the link to the registry is fgfr.imrare.org. It's pretty simple. And for any help and questions, you can email registry@bornahero.org. And this is an example of the home page. I think Carolina showed this as well. And again, the link to the registry is fgfr.imrare.org.
Now I would like to introduce Rosanna Samuel, PhD, clinical psychologist at Oxford University Hospital Craniofacial Unit. Rosanna earned her doctorate in clinical psychology in 2019 and has worked in the craniofacial service since then, working with children and their families and supporting them through surgeries and psychological distress associated with visible differences is like her dream job. Love Rosanna, and it was just so nice to get to meet her last year at the American Society for Craniofacial Surgeons and conference, and I just love this model, and I wish it could be done like everywhere and in like every hospital. So I'm so grateful for her. Thank you, Rosanna.
So we're from Oxford in the UK, so it's evening now for us, so we are winding down on our working week. So apologies if our minds are already on takeaways and finishing up for the week. But we're really, really excited to be here and really showcase the model that our health system allows us to develop, and we absolutely appreciate how it's different across the world. We have a lot to pack into a short amount of time. I'm really happy to be interrupted. Carolina, you are the only person I can see. So if you can give me a wave or something, all I can see at the moment is my screen. So hopefully something will pop up if somebody raises their hand. So as per the introduction, I've been working in the craniofacial service here in Oxford for the past few years. Prior to that, all of my experiences either in forensic services in prisons, or following that, it was more generally with children with other health complications. And then I've sort of settled in the craniofacial world and the world of visible difference. And Lydia, I'll let you just introduce yourself there.
Hi everyone, yeah, I'm Lydia and I also work with Rose in the craniofacial unit in Oxford, and recently joined last year. So thank you for having us this evening. Very excited to be joining you, I guess, this morning. Sorry.
All right. So there we go. So apologies if I'm telling you something you know here, but just to sort of ground our explanation of our service in our sort of UK-wide system here, this is a very simplified diagram of how it works over here. So you have the National Health Service, which is UK-wide, and then you also have NHS England, which, as it says on the tin, is the service for England. Unlike other health services, we're actually commissioned directly from NHS England. So we report solely to our direct commissioner, whereas other services are set up a lot differently, which means that they have different targets and different restraints put upon them. So we're really, really lucky to be classed as a highly specialist service. And we're one of 4 hospitals in England. As you can see, we've got Oxford, that's us, another children's hospital in Birmingham, Children's Hospital in Alderhay, which is in Liverpool, and Great Ormond Street Hospital, which is in London. We're really, really fortunate in Oxford that we're the only hospital who is not solely a children's hospital. So we're able to offer a lifespan service for all of our patients. So it doesn't matter if, as you will know, most patients have all of their surgeries and really intensive care early in life. But we're also able to offer procedures if they're wanted later on in life into adulthood and take on patients as adults over the age of 18. As you can see here, within each hospital, there's a multidisciplinary team. I've sort of outlined in Oxford, but those services are also in the other hospitals. So in our hospital, we've got consultant genetics, we've got the surgical team, obviously, which is plastic surgeons and pediatric neurosurgeons. We've got our psychology team, we've got a speech and language therapy team, and an ophthalmology team. All of those are teams within their own right, and then we all make up a multidisciplinary team around the child with the craniofacial condition. And then there's 2 services that's worth me mentioning who are not NHS services, and that's the Centre for Appearance Research, which is a research organisation at the University of West England who we partner with. And then there's also the Headlines partnership. So Headlines are the main UK charity for people with craniosynostosis. So that's a sort of overview that hopefully will then lead you to understanding our specific service. Oh, I'm just going to jump back. So the one thing I forgot to mention there was there's psychology within each hospital, and then the psychologists from each of the 4 hospitals have joined together to create a collaboration that we called Craniofacial Collaboration UK, and we're a sole research collaboration. So although every psychology team works predominantly clinically, we also do research, and we've joined forces so that we can share data and publish on a UK population. Which leads me on to our publications. I have got a full reference list at the end of the presentation, and to the conference organisers, I'm really happy for that reference list to be shared. You can see obviously here the dates and the titles of those collaborations. So at the moment, we're just coming to the end of a series of papers collecting data for children with single suture craniosynostosis. The reason for that is because one of the things we're able to do, given that every child has genetics testing, is we're able to have a much more homogeneous sample than some other centres worldwide, because we can include and exclude certain populations. So, for example, SMAD6 is a relatively recent genetic finding. So we're able to really answer questions for families where their child has a genetically confirmed diagnosis and those where there is not a genetic contribution to the craniosynostosis. So just to let you know where we're at the moment, so we're just coming to report on the longitudinal data. Lydia will speak a little bit more to the ages at which we collect routine data. And that's for sagittal and metopic craniosynostosis across from surgery through to age 10. And then where we're at the moment is to our future directions are looking at neurodevelopmental outcomes. So we're getting our heads together about to report on conditions such as autism, ADHD, dyslexia, dyspraxia in our population. We are thinking about projects about the lived experience and the experience of care in the UK, predictors of psychological adjustment, evaluating our interventions and our efficacy of those interventions, and thinking about themes such as stigma and wider understanding of craniofacial conditions. So for our general practitioners, our sort of family doctors that people go to first, and our referral pathways. And finally, thinking about attachment between parents and infants. Just a sort of closing remark on sort of research in our population, as I've mentioned, the difficulty when working with rare conditions, by definition, is they are small numbers. But what's also relevant for our population is there are so many different genetic findings, which means that it's sort of harder to get sort of more homogeneous samples. So that's something we're really, really mindful of in Oxford, with the benefit of our geneticist, Professor Wilkie, who's able to obviously influence our methodology. And so in Oxford, I've already spoken to this. These are our MDT teams that come together. We meet every week on a Tuesday, where our families come into the clinic room and we are all there. So the family comes into the room and sees a geneticist, the plastic surgeon and the neurosurgeon as well, if that's relevant to their care, a psychologist, a speech and language therapist, and an orthoptist. They will also always have an ophthalmology review at every clinic. And they have speech and language therapy and psychology assessments at various protocol ages. So it's just thinking about our psychology team. These are some of the research papers that we've published. This is led by psychology or collaborated with our MDT colleagues. So this is just Oxford research here. One of the fundamental roles of the psychologist in the team is really working individually with the family, but also the wider systems around the child. So Lydia and I, it's really routine part of our work to be linking with doctors from the child's home, health visitors who are a sort of nursing practitioner who visits a very young child up to the age of 5. Schools and nurseries, and linking with any relevant service really around the child. And sometimes we have children who are what we term as looked after children, so children who are in foster placements or who are adopted children, and there are wider health professionals for children who are looked after as well. So Lydia, I'm going to need you to interrupt me. One of the things I don't have is which slide number I'm on. I think this is my last slide, so I'll just speak to our psychology craniofacial service is a 5-tiered service. Lydia is going to talk us through the first 3 tiers. And you know, we've sort of set it out as this triangle. If you sort of think that tier 1 is the least intensive, for want of a better phrase, where we see many more patients. And as you go up the tiers, the intensity of the intervention increases and the number of patients that we're seeing at those tiers, by definition, decreases.
Great, thanks, Rose. So as the diagram shows, this is tier 1, and this is our kind of more global routine screening tier, in that this is offered to all of our families that come into our service. This input from a psychologist would be through our weekly MDT clinic that Rose described earlier, which is with all of our multidisciplinary team and happens every week. In that clinic, a psychologist will be screening for any kind of psychosocial needs within a family. We'll be kind of reviewing a child's development, and that will be through parent report, questionnaire reports, and also our own observations of the child within the clinic. We'll also be screening for any kind of mood or anxiety concerns, any behavioural concerns. We'll be screening for any educational needs for the child. And as they get older, if they're kind of developing any appearance concerns, we might be able to screen for that within this clinic. As well as part of our CC UK protocol, the specific ages that we will do these reviews are at 18 months, 3 years, 5 years. There'll be a telephone call at 7 years, and then at 10 years as well. Those with the syndromic diagnosis will attend the clinic as often as needed. So will come as clinically needed and indicated outside of those protocol ages as well. We also offer a monthly craniomaxillofacial oral surgery clinic as well, and that happens in much of the same way, and the psychologist will offer a triage call prior to the clinic just to screen for any kind of psychosocial needs within the family and for the child. And then during the clinic, we'll do much the same as I mentioned earlier, a psychosocial review of the kind of school educational work needs and any mood, behavioural, appearance concerns. Great, thanks, Rose. So then moving on to tier 2, again, this is a tier that is a preventative and proactive approach, and is kind of open to all of our families that come in through our service. So when a family come to our service for the first time, a psychologist will offer a new referral assessment. So that's a time outside of that clinic meeting that we've talked about, where we get to really know and understand the family, know their strengths and know their needs as well, just so that we know how to support them through their journey with us. And as Rose said earlier, we will work with the child up through to adulthood. So because we'll be with them for so long, it's really helpful for us to understand their kind of social setup. We'll do a genogram, so kind of a small family tree, know who's in the family. Again, we'll do a developmental review. We'll gather a family health and surgical history. And here as well, we can identify any risk or safeguarding needs. We also help families at this point with decision making around any kind of treatment options. And we also set aside monthly triage appointments so that if a family contacts our team with any kind of concerns around a psychosocial need, they can be popped into one of our triage appointment slots, just for kind of a brief kind of touch base with us. For families that choose a surgical route, we offer preoperative developmental screening assessments, and that's in conjunction with our speech and language therapists. And here again, we do a developmental review. But also what's really important for us as psychologists within the team, we just want to be able to support a family through that surgery journey and their admission in our hospital. So any kind of anxieties or worries, we can support through that preoperative assessment as well. And lastly, the endoscopic and helmet therapy is a really new treatment option in the UK, and it's not something that Oxford offer at the moment, but we are developing a protocol for when it is offered, in which we will meet with families to help support them with the decision making for treatment. Thank you. Okay. So tier 3, as Rose said earlier, the kind of as the tiers move on, we see less patients needing each tier. So this is where it starts to really break down in terms of numbers that are accessing psychology, and this is more of a brief kind of snapshot intervention from a psychologist. So this might be liaising with schools or liaising with kind of local health practitioners to the child. We might be part of kind of more wider multidisciplinary teams, offering advice, perhaps signposting, and also we might do a brief psychological formulation with a family to help them get to understand what the needs are within the family and for any kind of teams or systems around a child. So this first part of our tier, so we've got tier 4 twice, but this particular one is essentially a time-sensitive assessment and intervention. And what I mean by time sensitive is that it's relevant at a specific time in the child's journey with us. So, for example, if a child is admitted as an inpatient, it might be that we're doing inpatient work around anxiety or low mood. But also, it might be in preparation for surgery in terms of procedural distress. We also offer kind of cognitive functioning assessments, and this would be at really key transition points for a child, such as moving schools, moving year groups within school, and that's where it would be classified as time sensitive. And Rose, I know you were going to jump in on tier 4, so I don't know if you wanted to add anything further to this slide.
Yeah, that's great. Thank you, Lydia. So I was going to take over for the duration of the presentation and just speak a little bit more to what's most relevant for the population that the conference is focused on. So one of the roles I have is attending the monthly maxillofacial and oral surgery clinic. And so I wanted to just talk a little bit to our mid-face pathway, and this is our pathway for so-called Lefort procedures or frame procedures. So within this MDT, it's the same colleagues who make up this team. And we're just developing an MDT here in Oxford, a sort of standardized pathway. What you're seeing on the screen now is the psychology only pathway. So this is obviously quite complicated to look at, but very briefly, what it details is that for every patient having that surgery, they will have an initial assessment with me, which is really assessing the decision to have that procedure if it's an elective procedure. Obviously, for some younger children, it's a surgery that has to happen. But it's a huge surgery and it involves a sequence of surgical procedures. Here in Oxford, every patient having a frame has a trachea in situ. So a lot of my work in this role is around preparation and adjustment to having a trachea. And that's in collaboration with my speech and language therapy colleagues around teaching a child to communicate if they communicate verbally, and how to use a speaking valve. And a big part of my work has been sharing with school as well. So for a girl I was supporting a couple of years ago, I went to her school and did a presentation with her to her class to help explain her surgery, and I sort of took the teddy that we have with the frame on and just sort of explained everything and answered children's questions, really so that she didn't have to do that without somebody supporting her. I also do a lot of standardized assessments here. So in the little grey box at the bottom, I'm not sure you'll be able to read that, but those are standardized psychological assessments of mood, but also appearance satisfaction as well. Our last tier is tier 5, which is our highest intervention, which is a psychological intervention, but a routine weight. So this might be similar things that Lydia and I have spoken to, but essentially we offer any psychological intervention where the problem presented is related to the craniofacial condition or past or future treatment. And that's got to be central to the sort of our understanding of the difficulty. This 9 times out of 10 involves professional liaison, so working with schools and linking with other professionals in the child's home community. But also something I did want to mention is that we don't just work with the child and their parents. That is the majority of our work, but we will work with anybody in the family system who is affected. So sometimes that's grandparents. I do quite a lot of sibling work, but it could be a particular aunt or uncle or family friend who's particularly involved. It doesn't matter who it is. So long as they're important to the child, then we will work with them. Those interventions are cognitive functioning assessments, which are learning assessments, and that's our role in bridging the gap between medical information and learning needs, and bridging the gap between hospital and school. Long-term interventions, one-to-one patient interventions. So usually a child is 10 and above for one-to-one work. Family interventions where there's more than one person in the room with us, and we do a lot of parenting work where we're working with couples or single parents who have experienced difficulty as a result of having a child with a craniofacial condition. Just to give you a snapshot of our figures for last year, it runs May to May because May is our audit with NHS England. So May is always a big time of year for us. So in the last May to May year, there were 47 Tier 5 referrals, and you can see that it's a rough 70-30 split between patients with a syndromic diagnosis and those with what we term as a non-syndromic diagnosis. And that's patients where there isn't a known genetic factor. You can see that it's a real mix, but just sort of sneaking in at almost 30% is our work with sort of cognitive and learning assessments, and then mood and behaviour difficulties around 15% there. And just sort of protocol surgery assessments, which is everybody who has that there were 3 last year. Our psychological models that we mostly use are cognitive behaviour therapy models, such as acceptance and commitment therapy, compassion-focused therapy. Narrative therapy works really well with young children as well, and for some anxiety difficulties, graded exposure. Largely, our interventions are integrative in nature. Any questions? I'm sorry, I can't see if there were questions, so I'm going to, I think if I stop sharing, then I'll be able to go back to the, oh wow, yeah.
Yeah, so can you see it or do you?
So I can see,
Yeah, so I have, can you hear me?
Yeah,
I
could just-
can, yeah.
So I was wondering about the ceiling and I think the referrals. So the ceiling is 18 years old. You don't go beyond that, do you?
No, we're a lifespan service, so it doesn't matter what age the person is. If they have a craniofacial condition, they're under our team, then we will see them.
Okay. And I think you kind of answered that you would then refer them on to psychologists once they age out of the system. Yes.
Sorry, I'm not understanding your question. What do you mean
Um,
age out of the system?
Maybe you don't. Well, maybe you don't. Maybe that's what it is. So I'm wondering if you stop treating. I guess you don't stop treating people at the age of 18.
No.
See,
No, I've got young
Mhm.
adults on my caseload, 19, 20. I've got parents on my caseload who have a diagnosis themselves. It's not dependent on age. And we're fortunate because we're not a children's hospital, we're able to have that lifespan approach.
Okay, coming from the US, that's a very strange concept, and I'm trying to wrap my brain around it. So
That's
thank you very
okay.
much.
It's okay.
I have a question too. I think this is amazing. Just, like our kids. I mean, I know a kid in the East Coast that's had 90 surgeries at 5, and the medical trauma is just such a big thing. And so I just applaud you for, I mean, not even just the patients, but the parents and sometimes the siblings, sometimes get left out of this. And, I just know our parents just struggle so much with these surgeries and wrapping their heads around what this means. And there's just so many questions, and even the schools too, like it makes it such a better world for our kids when, I mean, I personally went to my kids' school to talk, but and the change of like, this is a scary thing to like we want to protect you. Like that was the whole, it went from that end to the other end, right? Just by talking about it and having that. And so I just so appreciate just sort of seeing the person and the family as a whole. And one of my questions was when you do the evaluation, is that so two questions, I guess. When you do the evaluation, then you kind of put people in the right tier. Is that kind of how it
Yeah.
goes? Okay.
Exactly, yeah. So everyone will see us, every single patient will see us because they come to clinic and we sit in that clinic. And what we're really doing in that clinic is making a decision about, do we need to follow up with this patient, and then slot them into whichever tier we need to do. So on both Lydia and my caseload, we've got many families, but across different sort of intervention levels.
Yeah, okay. And then so what happens if, like you do the evaluation, and is it kind of, when you do the assessment, is it kind of a conversation between you and the patient on how many times they get to have a visit with you guys? Like, is it a mutual thing, or is it like based on, I don't know, like numbers, or is it based on just your conversation? Like, do you decide, or is it kind of they decide, or is it kind of a mutual decision?
A bit of both. So we sort of present ourselves as a routine part of a child's care. So as much as they are coming to see the surgeon, they are also coming to see everybody else as well. Which is why in Oxford we all sit in the same room, so the family doesn't need to repeat the same information. So we're all hearing it. And then each clinician for their own discipline is making decisions really about what care that child needs. Obviously, for us, a lot of parents request our specific input, but also we're mindful of those parents who have more difficulty in advocating for the needs of their children, where we will be proactive in thinking a child will need something more from us, whether a parent's asking or not. And obviously a parent, I mean, we've never had it where a parent doesn't consent to treatment. But depending on the circumstances, we've got procedures to follow. And if it's in the best interests of a child to have any kind of medical input, then that's what will happen.
That's amazing. So like if they want 10 visits before a procedure, if that's their need, that's what you do.
Yeah. So that's why we have tier 4, which is time sensitive. So if there is a time restriction for any reason, we will meet that need. So we do a lot of preparation for surgery work to prepare siblings and parents and children for their surgery. And we don't control the surgery date, so we just have to find the time and we do it.
So now I would like to introduce to you Emily Durham, PhD, joined the TBCK Foundation in July of 2023 at the research engagement as a research engagement director. And I just wish every organization had this, and an Emily too. She holds a PhD in biomedical sciences from the Medical University of South Carolina and an MA in research ethics from Duquesne University. Currently, Emily is a postdoctoral fellow at Children's Hospital of Philadelphia, where she studies skull and brain development and changes caused by loss of TBCK and other neurodegenerative conditions. It was so wonderful to finally get to meet you in person at the Society of Craniofacial Genetics and Developmental Biology and conference last year. So just thank you so much for being here.
Okay, so I wanted to start by talking about TBCK Foundation and sort of our model for things. So we were founded in 2016 when TBCK syndrome was first described in the literature as an ultra-rare neurodegenerative condition involving developmental delay and hypotonia. Our founder, Nikki Stusik, is a rare disease mom, and our foundation has grown significantly over the last year and a half, having received a capacity building grant from the Chan Zuckerberg Initiative. And you can see our community is built with clinicians and researchers, as well as families with our patients and their advocates. We have a board of directors and a scientific advisory board and a parent leadership board. And then we have our whole network of other rare disease organizations, including Born a Hero and other parts of the CZI network. And really, the most important thing for us is that we have our TBCK warriors here in the middle, and they're always the focus of everything we do. And so our mission is to provide a dynamic system of support for our community through education, advocacy, and a platform for connection. And then we have this second part of our mission that's to connect science to the patient voice and accelerate research through fundraising and facilitate strategic collaboration and intentional goal setting, where we're creating a path to treatment. For TBCK syndrome, there are currently no treatments available. And so we really want to make our way towards treatment in the most efficient way possible. And so how do we do that? Where do we start? And so over the last 6 months, I've really started with thinking critically about how we're engaging not only our research population, but also our families. And in order to do that, there's a lot of listening, in both directions. And then we've also had a lot of success with trying some new things. So sometimes we end up being in the right place at the right time. And when I joined the TBCK Foundation, they were in the middle of a branding refresh, and that involved a complete website redesign. So I came into the foundation from the research community feeling a little bit like there's great oversight and connection at the top of the research community, but I didn't really know others at my level who were doing research. And so when the website designers came to me as part of the TBCK Foundation, and they had little like clip art icons on our webpage to represent research, I was like, maybe we could do this a better way. Maybe we can do something different. So the team at the TBCK Foundation gave me a little bit of money and said, sure, try this. So we did an image contest targeting the junior researchers in labs that study TBCK syndrome. And the junior researchers chance to win $100. Pretty cool when you're a postdoc or a graduate student. We ended up getting over 30 different submissions. Some of them were lab action shots where it was our researchers doing the research, which was really exciting for our community to just sort of get that picture into the lab. And some of them were these amazing works of art that happen as we're doing research. And so now we're able to share all of these images on our website. We're giving credit to these junior scientists for their contributions. And we have this great sort of water cooler moment of talking about these images and what they are and how they are connected to both sides of our community. So as I mentioned before, I was part of the TBCK research community before I joined the foundation. And back in the fall of 2022, I was able to be part of the second ever in-person convening of the TBCK community. And there I got to talk to TBCK warriors and their caregivers, as well as other scientists there about different aspects of TBCK syndromes. And one of the parents that I talked to me about her kiddo's teeth, because I'm a craniofacial biologist by training. So all of my questions are kind of in this area, which I know is very important to this community. And I was just wondering, you know, what's going on with these kiddos? What are things that families are experiencing? And this one mom was like, my kid has some teeth stuff. And I started to think about it as a scientist, and I was like, well, yeah, of course, there are dental issues. If you are primarily breathing through your mouth, this makes sense. And then I got to thinking about it a little bit more. And I know that our TBCK warriors also have brittle bones. And so then I started to think, well, if not having TBCK protein affects bones, maybe it affects teeth. And I happen to have a network of dentists that I know. So I reached out to a dental researcher and said, "Hey, do you want to look at these micro CTs of a mouse model of this rare syndrome?" And she said, "Absolutely, this is such a cool thing." So we started investigating. And just this past week, Dr. Katsura was able to submit for IRB approval to collect shed baby teeth from our TBCK warriors and really investigate what's going on with these teeth. We're seeing a difference in the thickness of enamel in our mouse model. And so we're really interested to see how this type of research progresses. And importantly, it would have never started unless that mom had said, "Hey, my kiddo has weird things with his teeth." So that is a success of my role of bridging that gap and really listening on both sides. Um, Importantly, listening does have to happen from both sides. When I joined the foundation, I reached out to all of the different researchers studying TBCK syndrome. And I was doing that right after I had had an experience of working with graduate students and undergraduate students in my lab here at Children's Hospital of Philadelphia with Dr. Elizabeth Bosch. And we had just done a phenotype genotype correlation study where we really investigated everything that's been published about the TBCK syndrome patients. And so I'm talking to this researcher who's from Harvard, and he's telling me about this this fish model that they have of TBCK syndrome. And the phenotype that they're finding is that there's a startle response when the light changes on these fish, but they're not really convinced that this is a neurological issue, and they can't really figure out what's going on here. And I said, "Oh, well, have you looked at the fish eyes? Because like 75% of TBCK warriors have vision impairment." And this offhand connection between our patient population and what was seen as an issue with this model turned into a new line of investigation for that lab. And now they're looking at structure and function in these zebrafish eyes to see if they can find a reliable phenotype in this model where we could start testing for drug development purposes. In addition to my other roles listening both to our patient population and our researchers, I was part of planning our virtual conference, which was held last fall. And I wanted to really get into more of this engagement of more junior scientists researching TBCK syndrome. And so I went to my colleagues at the TBCK Foundation and said, "I have this idea. Let's do flash talks," which I'm sure that everyone administering this meeting understands is a little bit of a nightmare, because rather than having these lovely 20, 15-minute talks, it's 5-minute talks, and maintaining a schedule and being on time and wrangling that many people is a little bit of a nightmare. But I saw it as an opportunity to engage our more junior research community and have them share their passion for research with our family community. And it was also in response to a family comment pre our meeting. "We've heard this research before. What's new?" So as a part of the scientific community, I know that research kind of moves slowly. And now that I'm understanding a patient community, that can be really frustrating. And always seeing things from this sort of bird's eye view that the principal investigators give is great. It's an overview of what's going on in the research, but it doesn't get to the more exciting day-to-day parts of science. And so our flash talks really got us to be able to do that. And then after our conference, there was a lot of excitement from our patient community where they wanted to hear things in a way that they could understand. It was a little bit too much science, not the best communication, even though in 5 minutes, our junior investigators did a terrific job. So again, we listened, and now we decided to try something new. And since our community is mostly Facebook-based, we've initiated a social media campaign for this year where we get eye-catching images from our research community and we add snips of science to share with our patient and family community. And our goal with this initiative is twofold. Firstly, it encourages participation by our junior investigators, and it really teaches them to think about how they're communicating their science. When you have to boil it down to just a sentence or two, it's much more difficult, and it's a great exercise for them to think about how they're communicating science for their grant writing as well as for their committees and other stages of their career. Our other objective with this is to create questions. So we really want our community of patients to look at these images and have a question and feel empowered to ask it. And so we feel like this Facebook, Instagram kind of forum is really going to lead to that communication. And based on our soft launch of this is what we're doing this year, which we did earlier this week, which generated a number of comments on our Facebook page. We're really excited to move into this year and start sharing science in this way and creating conversations. And speaking of those conversations, we also tried this Ask a Scientist Facebook Live event. So we know that our community is a global community and that Facebook is really where they come to get together. So we decided to spend an hour with me answering questions. And when we decided to do this, I thought I was going to spend an hour and no one was going to ask any questions. And it was just going to be a whole Facebook Live of me sitting in the lab by myself. It turned out that we had about 90 people view our live event. We had 34 questions. We filled the whole hour and then some. And then to date, we've had over 400 views of this, and it spurred more than 50 comments. It's also enabled our community to get to know me a little bit better. And so I get emails now from community members asking questions or connecting me with their dentist so I can connect their dentist with our dental researcher, or connecting me with their clinical team so that I can connect clinicians from Edinburgh to Philadelphia. And so we've really had a lot of success with very little input with this event, and we're really excited to continue to do it every other month this year. Our next event will be later this month, and we're so excited to have a soon to be minted PhD student who has ties to Puerto Rico, and Puerto Rico is very important to the TBCK community as that's where our founder mutation was identified. And he will be conducting this event completely in Spanish. So we're going to be answering questions about TBCK syndrome in Spanish in real time on Facebook later this month. And we're really excited about that. And later this year, we're hoping to have some clinical research experts and maybe even some genetic counselors join us for this event to really serve our community and open those lines of communication. So when it comes to having patient-led or patient-centered care and communication, we found that for our community, engaging both sides, engaging our researchers and engaging our patient population is necessary. We've also found that doing a good job of listening to everyone involved is necessary. And we found that trying new things can be really successful with really a small amount of input. So from the TBCK Foundation, our recommendation would be to just start trying to build that bridge between those two sides. And with that, I'd like to thank my colleagues at the TBCK Foundation and thank you for your attention today. I'm happy to answer questions. I saw some come through on the chat. You're also welcome to email me at emily@tbckfoundation.org because I love to talk about science communication in this rare disease space. Thank you so much for having me today.
Thank you so much for that. And that's what I mean. I think everybody needs an Emily. So the title would be Research Engagement Director, right? Is that what every organization needs? And it's you work through the organizations, right? And what kind of title do you look for in a person in a research engagement director? Do you know, like?
So I've had the opportunity to meet a number of other individuals in my position. There's a lot that are coming from like the public health
Okay.
arena, like Deanna Chisholm at Tango 2 Foundation is doing wonderful things there, and she comes from a background of public health. I also have talked to other people in my position, so sort of at the end of the postdoc looking for something new. And when I was at the CZI Science and Society convening last fall, I recommended rare disease organizations sort of posting in that space for postdoctoral researchers. Right now is a really interesting time because postdoc salaries nationwide are pretty low. And so there's a lot of postdocs that are looking for a part-time gig. And I think our model with the TBCK Foundation, where I am part-time, it works really, really well because I'm able to balance between my postdoctoral work and work for the foundation. And I could see that working for other postdocs as well.
Now I would like to introduce Rosie, who is 5. She's going to have a video for us, and she is just a sweet, cute, and chatty little one. She and her feet and hands like to be part of all the conversations that I have with her mom. I love what her mom said in her biography. Rosie, known for saying bets whenever someone doubts her abilities, and has become a beloved friend to her community. Just say hi, and you've got a new best friend.
Hi. Hi. Hi.
Rosie, can you tell me what means friends?
I go to happy and quiet and sweetheart and
Isla.
and Sarah.
What do you do with friends?
Play. I am joyful and play. So I go to restaurant with my family. I can see Lily looking at laptop.
So family is friends too?
Fairies are friends too. So I have my Christmas tree, and I make my paper today, and he paid for me.
So friends make gifts for each other?
And when it's together, so I just went over there, and I was looking up. That's why outside.
Can you tell me about your friend, Dr. Taub?
He's how today I went to you. He's doctor. T-A-U-B.
This doctor
This doctor
is a surgeon
is the
who helps kids
his health is
like me.
like me.
So please welcome him today.
Please open now. Bye.
That was very sweet. I can't top that. There's no way I can beat that. That was awesome. Awesome. Anyway, I'm honored, delighted, excited to be here. Thank you, everybody, for inviting me. The panel that I'm introducing, I did not pick. I was not good enough to pick these people. These are awesome people in their respective specialties. And I'd like to give each one of them a little shout out before they're going to talk about their corner of the world and what they do. The first is Dr. Jake Dahl. Despite growing up a lot of his time in the Philadelphia area at Villanova and Penn State and Thomas Jefferson, he's currently a pediatric otolaryngologist at Seattle Children's Hospital. And he's an associate professor in the Department of Otolaryngology and Head and Neck Surgery. He has a real interest in basic clinical science research related to vascular anomalies, which we do, tracheal malformations, airway management in patients with complex craniofacial disorders, like you saw, and certainly patient quality and safety, which really has to be commended. My second is Dr. Ken Nishal. Dr. Nishal is the chief of the Division of Pediatric Ophthalmology and Strabismus at UPMC, which is Pittsburgh's Children's Hospital. He directs the pediatric program development at UPMC Eye Center, and he's a professor of ophthalmology at Pittsburgh. He's from King's College London, so if he has an accent, you'll understand why. He did his ophthalmology at Oxford and his fellowship at Sick Kids in Toronto. He was appointed to Great Ormond Street, which we all know in London as a fantastic institution in '99. And he was recruited back to UPMC in 2011. Next is Susan Machi Perrine. She's a PhD. She got her BS and MS degrees in animal sciences from Penn State. That's two Penn Staters. And then went on to complete a doctorate and intercollegiate graduate degree program in physiology. That's between Penn State and the University Park campuses. She completed a postdoc in craniofacial research in Joan Rickmeister's laboratory, who I know and quite honored to know, and continued on with research in the Rickmeister lab until July 2023, when Dr. Rickmeister retired. She and her colleagues now lead the lab and continue to pursue developmental craniofacial research. She currently holds a position as an associate research professor in the Department of Anthropology at Penn State and dedicates the rest of the time to family, which is great. And finally, from outside the US, Dr. Marcela Cabal Castro. She's a Colombian plastic surgeon, pediatric plastic surgeon, who graduated in 2010 from Universidad El Bosque and did a subspecialty in maxillofacial and craniofacial surgery at Fundación Universitaria de Ciencia de la Salud. Pardon my Spanish. And she's been working both in aesthetic side and in the reconstructive side for more than 12 years in Cali, Colombia. colleagues of mine are traveling to Colombia just for vacation. I told them it's a wonderful place to go. She has a multidisciplinary interest and a long-time follow-up of these kind of treatment processes, which I think is great. She also operates voluntary for many years, teaching at the university in Cali with the plastic surgery section. I think we'll start with Dr. Dahl. Thank you very much for joining us. It's an honor to be on a call with you, and I turn it over to you.
Great. Thank you so much for that very kind introduction. Can everybody hear me and see
Yeah.
my slides okay?
Yep.
All right. So I'm going to be talking today about a bunch of work that we've done here in Seattle around airway and diagnosing airway abnormalities in our FGFR patients because this is a huge, impactful part of the syndrome that can be managed and provide great patient outcomes and improve the safety of our patients. So I don't have anything to disclose. As an airway surgeon, I kind of look at the spectrum of congenital tracheal malformations. And what you see here in panel A is what we'd expect. So there's your thyroid cartilage, and then the trachea is these blue rings with these purple interspersed connective tissue. And the rings are C-shaped, and the back wall of the trachea is actually a muscle. And so this is what a normal trachea is. Now, there's a whole host of different tracheal pathologies that we see, but the one I'm going to talk about today is a tracheal cartilaginous sleeve, or TCS. And this is when you have a fused anterior tracheal wall that's all cartilage, and you don't have the fibrous, more flexible tissue in between. You still have the posterior muscular wall. And why this causes airway obstruction is still a matter of debate, but we do know that this tracheal cartilaginous sleeve can cause significant respiratory issues in neonates with FGFR-related syndromes. So here's a little bit more about a tracheal cartilaginous sleeve. What you can see in the images here, this is a normal trachea. So you see these C-shaped rings, and this is on bronchoscopy. So we're looking inside the trachea through the patient's mouth. And in a patient with a TCS, you don't see those C-shaped rings. You still see this kind of fibrous muscular posterior wall on both of them, but there's a very distinct abnormality in this image here. And really the gold standard diagnosis is at the time of tracheostomy. And this is a patient that I'll show pictures of later, who at the time of his trach, we were able to document that he has a TCS. And why this is important, there's a couple different theories out there that our group is looking into. One is that because the abnormal shape of the trachea leads to impaired respiratory clearance or respiratory epithelial function, kids are more likely to suffer from lower airway disease. And then another idea is that the TCS actually narrows or causes stenosis in the airway. So again, this is mostly found, I think pretty much exclusively found in patients with FGFR-related syndromes. The first 4 case reports actually came out of Seattle Children's and were published by my colleague and mentor, Dr. Andrew Inglis. And there's an interesting study, it's an old study, that showed that 90% of patients with a TCS had mortality by age 2 without a tracheostomy. And I don't think that's the case at all right now. But these can be difficult to diagnose. You can't use standard imaging modalities like MRI or CT because they don't detect cartilage. Endoscopy can be challenging. The pictures I showed you earlier are like a pristine airway, but a lot of the time these kids have secretions. They're small. They don't love anesthesia, meaning that it can be difficult to do these procedures. And so it can be hard to diagnose this endoscopically. But in talking with radiology colleagues and others, ultrasound might have utility. And like I said before, the gold standard diagnostic modality for TCS is actually direct visualization of the trachea at the time of tracheostomy. There's a lot of people that are going to talk about FGFR biology here, so I'm going to go through this quickly. But it's receptor tyrosine kinase. It's got roles throughout the entire body, and it's really involved in growth and differentiation. And we know that the mutations in these receptors underlying the FGFR related syndromes are due to gain of function and activation of the receptors. So that's why it's what we would consider like a mitogenic or pro-growth type of insult. And further, we know that different mutations, specifically in the FGFR2 gene, are associated with different syndromes, as well as different biology. So certain variants seen in Cruzan and Behr-Stevenson need the FGF molecule to interact with the receptors to have it become overly active. Or excuse me, they do not need the FGF molecule to have the receptors become overly active. Whereas a pair syndrome is more ligand dependent, and that's when you have the FGF present and overactivation of the receptor system. Now, thanks to a lot of collaboration through a number of people who are attending this meeting, our group did look at airway specimens in mouse models of FGFR2 related syndromes. And what we found in looking at these mouse specimens is, first of all, the only true TCS phenotype was seen in mice that had 2 copies of the FGFR C342Y mutation, which is in contrast to humans, where we know that there's only 1 copy of the mutation in patients with these syndromes and and with the TCS phenotype. The other thing we found, which is interesting, is that the patients with, or the mice, excuse me, with the TCS phenotype actually had a wider trachea than those who did not. So that kind of calls into question, that the thinking that TCS leads to airway narrowing, which leads to pathology. And we're doing some work with colleagues in Seattle Children's, Dr. Stephen Reeves and Dr. Lori Eldridge and Dr. Kathy Millen, to study this further. Our hypothesis is that actually the main pathology is a disruption in respiratory epithelial function that leads to impaired airway clearance and lower airway function. That's really causing the respiratory issues in these patients. So more to come on that front. We've looked at the genetics of patients with TCS diagnosed at our center. These are not super common. In the old days, a lot of the diagnosis was made in the absence of genetic testing. But what we do find is that there are certain mutations that seem more common with TCS, and that would be the FGFR W290C, which leads to Pfeiffer syndrome. But there are a whole host of other FGFR mutations in which we've seen with patients who do have a TCS. So more to come on that genotype-phenotype relationship. Interestingly, when we look at airway interventions in 30 patients retrospectively with a TCS and an FGFR-related syndrome, not all those patients required tracheostomy. Only about 60% did. Most commonly, again, in Pfeiffer syndrome. But even then, there's Pfeiffer syndrome patients who, at the time of this study, didn't have a trach, had a native airway. And this is where I say our data kind of conflict with that previous data from 2010, where not all of these kids need trachs. And in thinking about this and talking with my craniofacial pediatric colleagues and my craniofacial surgical colleagues, I think a lot of centers aren't familiar with these patients. They're not familiar with airway management in these patients. And so trach is a safe thing for these kids. But if you have a center with this experience, it's not necessarily required in all patients. And again, when we look at the genetics of this, this Pfeiffer syndrome, FGFR W290C jumps out at us as patients who may need a trach earlier than others. Again, this is a small study, so it's hard to make any overarching conclusions about some of the other syndromes, but the take home is that not all of these patients need a trach early on. And it's important to help guide families and caregivers in the clinical teams to make a thoughtful decision about whether or not a patient would benefit from a trach, because there's lots of potential morbidity and mortality in young children with trachs. So it's not a decision that should be entered lightly. So in working with my radiologists, who are way, way, way smarter than me, we were just talking to me like, can we diagnose tracheal malformations with an ultrasound? And Jeff Otchin and Francisco Perez are two of the radiologists I work with closely, and they're like, yeah, we think we can do it. So we had a patient who may or may not be well known to this group in the NICU, and we asked the family, can we just ultrasound the neck? And sure enough, what you can see here, this stripe is just a straight block of cartilage. Ultrasound works based on the density of the tissue. The least dense, and so this really dense tissue here in the airway looks like the trachea. And then the radiologists were so excited, they went next door and talked to another family whose baby was in the NICU for a different reason, and they ultrasounded that baby's neck. And here you can see very discrete tracheal rings. So based on this, and this just gives you kind of the overall kind of landmark of what we're looking at here. And this is a TCS patient. You can see it right there. The radiologists were like, yeah, we think we can diagnose a TCS in a neonate on ultrasound. Now, we love ultrasound because it can be done at the bedside. It doesn't require anesthesia. It's not associated with any radiation exposure, and it can be done pretty quickly by a skilled technologist. So we decided to study this. So we got 2 patient cohorts, patients with known TCS. And this goes back to a point that Carolina mentioned earlier about how active and engaged this patient population is in participating in studies. So as soon as we started recruiting for this study, I was actually getting emails from parents who I didn't even contact yet to participate because it had been known in our local network that we were going to do this. Which is just an amazing, amazing characteristic of our patients and families. So we took a group of patients with TCS and age-matched controls who underwent neck ultrasound. We had the images reviewed, blinded by 3 fellowship-trained pediatric radiologists. They were looking for normal tracheal cartilage and presence or absence of a trach tube. And then we did some stats, and we've got a statistician who's good at that. And so Dr. Wong did the data analysis for us. Here is our patient population. So we did have a mix of Pfeiffer, Aper-Cruzon syndrome, and a pretty wide age range from a 1-year-old to 18-year-olds. And so when we did the analysis, we found that the cartilage type, either presence or absence of a TCS, was correctly identified over 90% of the time. Tracheostomy presence, same thing. And then sensitivity and specificity for detection of the TCS are at 88% and 100%, which is a really, really high numbers for the non-clinicians for any diagnostic study. Now, the caveat is this is a small population. The ends are small, but it's done in an appropriate way from both a experimental design and data analysis standpoint. And it's the same thing for whether or not a trach is present, which is less relevant here. So basically, the age did not, we also looked at the impact of age on whether or not we can diagnose TCS with ultrasound, and doesn't impact it. And then the ability of different radiologists to make these assessments was tested. And again, the numbers here are very strong, showing that each radiologist amongst themselves were good at reproducibly making these diagnoses, and the entire group of radiologists who look at this collectively were also good at making this diagnosis. So what does this actually mean for patients? That's why we're all here, and that's what we're interested. So we feel that ultrasound is a sensitive and specific screening tool for the presence or absence of TCS. It can be done in the bedside, in the NICU, no sedation, no radiation exposure, no anesthesia, and it's good information that can help then guide additional diagnostic evaluation and treatment planning. If you, and just for an example, if you have a patient, say, if you take all of our data collectively with Pfeiffer syndrome that has a W290C mutation, and you do an ultrasound at the bedside, and there is a TCS, again, our numbers are small, but the data would suggest that that patient would benefit from an early trach. However, if you have a patient with a different syndrome, say Cruzon, and they do not have a TCS on the NICU bedside ultrasound, they may not need a trach. And so we manage those patients very differently. And our goal is to identify the right patient for a trach at the right time and try to not recommend that procedure in patients who don't really need it because of the risks, the morbidity, and potential mortality. And so we feel that this is a very easy way that we can get patients and families information to help move their treatment planning forward. And it's something that we do in our NICUs when we do see neonates with FGFR-related syndromes. So, as I said earlier, we couldn't do this without our patients and families. Everyone jumps in to do these studies. So many patients and families made special trips to Seattle just to participate in this. And this is perhaps one of the greatest Christmas presents I've ever received. This is a patient of mine from my previous institution at Riley Hospital for Children. He's the first FGFR syndromic patient that I took care of as an attending surgeon. And his mom sent me this text just before Christmas with some pictures. And so I put this up here just to remind everyone that these kids can do really, really well. They do benefit from teams and clinicians who have expertise in this area. But these kids are rock stars and they thrive. And again, I was almost in tears, and that's not my personality when I got this text randomly just before Christmas. So with that, I just want to call out our research team. Doctors Richardson and Lamb really help with this. Dr. Wong is our amazing biostatistician. Dr. Achin is my radiology collaborator on this. And then Kelly and Natalia are our amazing ultrasound techs who initially were a little terrified of these babies in the NICU and now are experts at doing these studies. So with that, I would like to conclude. I'd be happy to answer any questions from the audience if I think we're ahead of schedule, so there's a opportunity. Yeah.
Yes, we have about 10 minutes for questions, so feel free to ask away.
I think one question that we get from clinicians when we present this work is how hard is it to train your radiologists and radiology techs to do this? And the answer is it's not. And the follow-up answer is our team is happy to work with and talk to any centers who are interested in initiating this type of diagnostic ultrasound for our FGFR patients.
Yeah, Dr. Dahl, I was going to just ask that, like, how do we get this to other centers? So, yeah, what's the plan for that?
Well, we're publishing that paper. It's been a little bit slow, but we're just about ready to submit that paper for publication. So that will kind of bring this out in a more data-driven manner. But people just would need to contact myself well, just contact myself at Seattle Children's. And we would be happy to put you in touch with both the technologists and the radiologists to implement the protocol. It's very straightforward.
So if we're doing it if we're helping you connect you to other centers, who would be the point of contact that you would need, that we could connect you with? Or, I mean, to start that conversation? Would it be like, I don't know, the regional director, or would it be like the surgeons, or just to get that conversation going and pushing to implement that in other centers?
It'd probably be the Craniofacial Center leadership, the Craniofacial program leadership, that would help drive that, and then they could identify the radiologists interested within their own programs. Obviously, these kids get tons of imaging for other indications, and so the radiologists are very familiar with them. And this is again a standard technique that can just be applied.
Yeah, this is so great. And wait, we have a question. You have a question on the chat. Did you want me to ask you?
Yeah, so I can read it out. So Marcella Cabal, what are the characteristics of your ultrasound to be able to adequately observe this tracheal alteration? That's a great question. I'll have to get back to you on that. It's just our standard ultrasound that they use for all the diagnostic ultrasounds here. It's nothing fancy. It's not a point of care ultrasound, but you don't need a super fancy, super expensive ultrasound to do this. So how deep do you need to see? In neonates, not that deep at all, because the trachea, the TCS is so dense. You see that really nice stripe there. And I didn't include this in the talk, but we did publish another paper, Dr. Achin and myself and the rest of the team, that actually describes the radiologic characteristics of the tracheal ultrasound, both in normal tracheas and in the TCS. And there is this shadowing effect that's been well described in the radiology literature, specifically with ultrasound in different densities. And that's exactly what is seen here. And this is something that, ultrasound is so widely used in pediatric radiology that regardless of where your center is, your pediatric radiologists are going to be familiar with this technique and with this particular shadowing effect. Yeah, there's another question. Are there specific genetic mutation of FGFR2 related to TCS? I would say our study population is too small to really definitively answer that question. Our N is 30, which is probably one of the larger populations reported in the literature. But I would say that Pfeiffer W290C, those kids reliably have a TCS. Other mutations, it's less. There's more variability in it in the literature, and part of that I think is because these things are hard to identify, and not all patients need trachs, and so then endoscopic interpretation can be challenging. And so there are a number of different and non-FGFR related syndromes reported in the literature to have TCS, and I personally don't believe that those are accurate reports. And that's my personal belief, but in talking with airway surgeons around the country and even around the world, I think that's a widely held belief.
Any more questions for Dr. Dahl?
Great. And again, I just want to thank our local patients and families for their amazing participation in this study, because I do think once we kind of roll this out and other centers start seeing it, this could have a lot of benefit for patients seen at other centers and throughout the world. So thank you.
Thank you, Dr. Dahl, for all the amazing work. And you just always are so collaborative with everything, and so great with our families. And it's just, you're so easy to talk to. So I just really appreciate all your support with everything, because you've helped us with everything. And with our patients, whenever we've had a question, you've always been so responsive. So I just truly appreciate that too. So thank you.
Yeah, my pleasure. Thank you.
Okay, I think Dr. Taub, are you still there? Okay, I think he might have stepped out. So, all right, so I will, I think he did the introductions already. So Dr. Nishal, did you want to continue?
Did. Thank you very much for inviting me. I appreciate the opportunity to discuss this subject that's close to my heart. I hope you can, I'm going to go to share and then I'll toggle so that we're seeing the right, there we go. I hope you're seeing my slides. Is that,
Yeah.
that great, thank you. So I just want to give you a little bit of background about myself. So I started looking after children with craniosynostosis in 1994 at Oxford with Hung Cheng, who was our ophthalmologist, and Stephen Wall, who was head of the craniofacial unit. And then I went to Sick Kids and I worked with Ray Bunsick on craniosynostosis. Then I became an attending at Great Ormond Street and worked with Richard Hayward, the head of the neurosurgery service there. And then I was recruited to University of Pittsburgh Children's Hospital in 2011 and worked here with Joe Losey and Ian Pollock and now others after them. So let me take you through a journey of my understanding of the visual surveillance in craniosynostosis. I'm not going to talk about the strabismus because that's a whole other talk. And if I did both of them together, it would go well over the 28 minutes. These are my financial disclosures, but none of them are pertinent to today's talk. So what struck me when I started at Great Ormond Street is that the technical surgery, the craniofacial surgeons had become so good at the aesthetics. You know, you could have a child who had severe craniosynostosis at birth and who could end up looking normal over a number of years. But when you look at this picture, what I want you to notice is that while this handsome boy is looking at you with his right eye, his left eye is drifted out. And it's drifted out because his vision in that eye is poor. So as the aesthetics have improved, the question really for me was, can we improve the functional outcomes for these children? You all know what craniosynostosis is, and I'm not going to spend a lot of time on that. This is just a 3D CT scan showing a bicoronal synostosis. And I'm sure many of you know about the different genetic causes. This is a great paper published in 2023, which gives a nice sort of summary of the genetic causes, some of which were alluded by the previous speaker. What's really interesting is that I had the good fortune to work with some of the people at Oxford who discovered the FGFR2 mouse, as they called it at that stage in 1994. So I was able to see in a mouse model what exactly was happening to brain development when as the craniosynostosis developed and the mice developed. So that was a really important insight for me. As has been said, the FGFR2 mutation cases causing conditions like Apert syndrome, Crouzon syndrome, and Pfeiffer syndrome, that's a gain of function. And that, I want to show you, has a really important consequence on the eye. So the first question when I started at Great Ormond Street, where, by the way, they decided it was a really good idea that on a Thursday, the only patients I would see would be patients with craniosynostosis. And so I saw syndromic synostosis, I saw non-syndromic synostosis, and I can tell you rapidly, it became a very well-known day because we would see anything from 90 to 100 children in a day with a team of about 27 of us, all ophthalmology related, and evaluate these children. While it was painful for both the families and myself, because we're trying to get through this workload and make sure that we were giving them a good service. It was instrumental in helping us understand some fundamental problems. So the first question was, is there a problem? And we reviewed 141 cases of syndromic craniosynostosis that went through that clinic. And what we showed was that in 40% of cases, no matter what happened, in their better seeing eye, the vision was worse than 20/40. So in the better seeing eye, the vision was worse than 20/40, no matter what they had done to try and alleviate any raised intracranial pressure or any breathing difficulties that these children may have. And you may say, why is he talking about breathing difficulties? And I'm going to explain that to you and show that to you in a minute. So the question really was, when I was at Oxford, we were always told that these children got an optic neuropathy. In other words, the optic nerves and the visual pathways got damaged because the brain was growing and the skull vault wasn't growing because of the craniosynostosis. And so we used to call that craniocerebral disproportion. That was the term that we used. And so I was always taught as a senior trainee that it was the optic neuropathy that caused the visual damage. Well, when we looked at this cohort of children, what we found was that the commonest cause of visual loss is something called amblyopia. Amblyopia is the commonest cause of visual loss in any child, not just a child with craniosynostosis. And what it is this. When a child is born, the brain doesn't know what it's supposed to see. Between the ages of 0 and 8 years, it learns to see. If the input to the brain is disproportionate, in other words, one eye is normal and the other eye has astigmatism, in other words, the eye is not round, it's more like an egg shape, or it's too long-sighted, or it's not pointing in the right direction, then the images from that eye don't get laid down in the seeing part of your brain. That is called amblyopia. And the way you reverse that, when it only affects one eye, is that you patch the good eye and you make the brain, with the correction that you need, either glasses or just putting the patch on to straighten the eye, you make the brain take on the new images. So when we looked at the amblyogenic factors in this cohort, 70% of the children had strabismus, 18% had a difference in the power of the eyes of greater than 1 diopter, which is amblyogenic, and 40% had greater than 1 diopter of astigmatism. When you have greater than 1 diopter of astigmatism, it means that the image falling on the back of your eye is not, so a circle is now oval, and the brain starts to distort those images. So you've got amblyopia, and I took this image from this website, and then you've got what we call strabismic amblyopia. When the eyes are not aligned, in the developing visual system between the ages of 0 and 8, instead of seeing double, the brain suppresses the image from the eye that's not looking at where it wants to look. So if you look at this lovely boy, who was a patient of mine and had Seth-Richardson syndrome, he's got 3 things going on. Number 1, the left eye is not straight compared to the right. So he is suppressing, his brain is suppressing that image, and he's developing amblyopia. The second thing is he's got ptosis, a droopy lid. It is pressing on the cornea, which is shown here on the bottom left, and that creates astigmatism, which means that a crisp, clear letter A now looks distorted. So before we even look at the optic nerve and wonder what's going on inside the skull, this child has got amblyogenic factors that are going to affect his eventual visual outcome. And what I found was happening is that these children would be seen by people who were not used to seeing them, and they would panic they would be so worried about the nerve, they would forget the simple things. And here's the other thing. Many of you who are parents listening to this or providers will know that when you have a narrow airway, which these children often have, there is a respiratory effort that they have, which makes them sweat a lot. They also have shallow orbits, which means their eyes are more prominent. Now, if I tell you that normally you would patch a child to make the worse eye see better, the patches don't stick. And what's worse, they rub on the eye and they can cause ulcers. So you have to change the way you do the patching. And what you do is use a drop called atropine, which blurs the vision of the better eye so that the less good eye starts to see better. So a simple change in practice helps improve their vision. Well, they get exposure keratopathy, and I'm going to talk about that in a minute. And they also get optic neuropathy, and what I prefer to call visual pathway dysfunction. Now, when we talk about visual pathway dysfunction, I want you to notice that the visual pathway is the eyes, the retinas, which are like a film that catch light. The light goes along the optic nerves and it goes to both sides of the brain to what we call the visual cortex. So that's what happens. The VEP, something called a VEP, a visual evoked potential, allows us to assess what that visual pathway is like. It's not telling you if the child can see. It's telling you if the visual pathway is being damaged by whatever cause. I'm going to show you this video. Now, Amy, I'm relying on you to tell me if you can hear any music. I'm hoping you can't because I can't speak over it. Can you hear any music?
Oh, you're good.
Okay, good. So this is a child who was, and I'm just going to, oops, I've gone to, let's try again. So before we start, this is a child whose mother worked, was a technician who worked in our electrophysiology lab. And you'll see he's a superstar. He's going to be a famous actor one day, I'm sure. And this, I will talk you through how you do a VEP. He says, let's try again. Okay. So you have to clean the skin at the back of the head and put 3 electrodes on. You can put 5, but it's the seeing part of the brain at the back that we're trying to record from. You then put electrodes on. There's a common and an earth, and all the points that they're placed are strategically placed due to positions on the skull. So we show the child a cartoon, so we grab their attention. And then we flip these black and white checkerboard patterns. And when we do that, we get a recording. We have normative data for every age group, so we know what that data should be. The pattern VEP really is assessing the central visual pathways, but we also test the overall pathway with a flash of light, which we're showing you now. We'll do both eyes for both types of test, and then we try and do one eye at a time if the child will let us. We are not, I repeat, we are not trying to see what the visual vacuity of the child is. We're trying to see if the visual pathway is intact. And I'll explain why that's important. What we did was we looked at 114 patients with craniosynostosis and did pattern reversal VEPs with what I showed you. And what we found that 60% were abnormal. 60%. Now, does that mean, when we got this result, we were a little bit surprised, but wait a minute, does that mean that every child, or 2 out of every 3 children who have craniosynostosis can't see? Well, we knew that wasn't true. But remember I told you that we base the points of the electrodes based on the skull. Well, if your skull has an abnormal shape because it's asymmetric, now you're not necessarily looking at the same points inside the brain, that inside the skull, that you would have been doing in somebody who didn't have craniosynostosis. So what we showed was that you need a baseline of that child, and then it's not the absolute numbers, but the change in subsequent VEPs that helps you understand if there's a problem or not. I'm going to come back to that. It's important to notice that all these 114 patients were before any intervention had been done. Now, you remember I talked about exposure keratopathy. One of the things that always struck me is when these children get ulcers in their eyes, and thankfully I don't see it so often nowadays, it's a different type. The epithelium, the covering of the cornea, is much more heaped. And it turns out that KGFR, which is keratocyte growth factor receptor, is an isomer of FGFR2. So if you have a child who has an FGFR2 related craniosynostosis, if they get exposure keratopathy, they often get these white scars that are quite heaped. And it's because the KGFR that is in their cornea is an isomer of FGFR2. Now, what I don't know and what I haven't done is any basic science experiments to show that that's causal. But it's interesting. It's an interesting observation. Nowadays, we do prophylactic lubrication. I do temporary or temporizing tarsorrhaphy. That's when you suture the lids. And it's temporary because when you suture the lids, if the eyes are being pushed forward, the pressure in the eye will go up. So you need a more permanent solution, such as a midfacial distraction or a monoblock advancement, to get rid of that shallow AC and reduce the exposure keratopathy. So one of the most important papers that my group did was this paper where we did a correlation of visual acuity, optic disc appearance, and pattern visual evoked potentials in syndromic craniosynostosis, pre and post cranial vault expansion. And what we found was in all of the children who were undergoing the vault expansion because it was deemed necessary by the craniofacial team, 50% showed no optic disc swelling. And I have to tell you, all of these children, the syndromic ones we had, were FGFR2 positive. So imagine we look for optic disc swelling to see if the pressure is raised in the head, and in 50%, it was not raised. However, when we did serial pattern VEPs, there was a decrease in the amplitude prior to the surgery, and that amplitude increased after the vault expansion. So I'll explain to you why I think that's happening. This is another case that we published in Pediatric Neurosurgery some years ago, where sustained raised intracranial pressure was only implicated by a pattern reversal VEP after cranial vault expansion. Let me show you the case. The optic nerve looks a little anomalous, and at every stage it looks about the same. And we found that the VEPs were deteriorating, so we got a repeat CT scan, and the child had developed hydrocephalus. And when that was treated with a shunt, the VEPs improved. You'll see that the optic nerves, the optic nerve appeared to be the same. So here's the question. Why can't we rely just on visual acuity? Because when you do visual acuity testing, it's subjective. As children get older, they get better at doing visual acuity testing, even if the whole visual system is deteriorating. So what I couldn't understand is why on earth would the optic nerves not swell? So we looked at the expression of FGFR2 and FGFR3 in the normal embryo orbit, human embryo orbit, and this is what we found. FGFR2 is heavily expressed in the optic nerve sheath and in the muscles of the eyes, around the eyes. But FGFR3 is only expressed in what is cartilage and is going to become bone. So when you have a gain of function mutation, in order for a nerve to swell because there's raised pressure in the head, there's got to be elasticity. When there is no elasticity, the nerves don't swell. So if you are only looking for optic nerve swelling as an indicator that the pressure in the head may be elevated, you are going to miss up to 50% of all cases, according to the study that we did. Now, I don't know if that's an overcall because we were a tertiary and quaternary center, or whether that number is 20%. Whatever that number is, it's not zero in children with FGFR2 mutations. Interestingly enough, children with FGFR2, Pfeiffer, Cruzon, Apert, are also known to have missing muscles, extraocular muscles, as shown in this arrow. And we can explain why. Because instead of having normal muscle, it's replaced by fibrous tissue, because, as I've shown you, FGFR2 is indeed expressed in extraocular muscle. And for those of you who may have patients or children who've had any surgery when the eyes have been misaligned, the surgeon may come out, if you have FGFR2 mutations, if the child has FGFR2 mutations, and say the muscle was very abnormal. And it's abnormal because of the extra fibrous changes that are present there. Okay. This was perhaps one of the most important papers that we did. Susanna Layton was a phenomenal ENT surgeon who unfortunately passed away some years ago, but she was an amazing colleague. And I remember walking out of Great Ormond Street with her one day and saying, you know, I'm really worried about this particular child who has consistently swollen optic discs. He's got Cruzon syndrome, and we're doing the VEP and it's deteriorating, but everybody tells me that his intracranial pressure appears to be normal. And I said, I think he's got sleep apnea, and what's happening at night is that his carbon dioxide levels are going up. And she said to me, so what do you think? I said, could you take out his adenoids and his tonsils? And she did. And the minute she took out his adenoid, his tonsils, not only did his VEPs improve, but the swelling in his optic nerves disappeared. So the question is why? Well, Richard Hayward was the head of the neurosurgery department at Great Ormond Street, and I spoke to him. I said, you know, when you're an adult, there is a syndrome called Pickwickian syndrome. Pickwickian syndrome is when you're morbidly obese, and when you sleep at night, you get obstructive sleep apnea. And because you're an adult, you're in your 40s or your 50s, your vascular supply is not normal. And so your intracranial venous pressure goes up. And he looked at me, he said, did you know that a proportion of children with FGFR2 related craniosynostosis have absent venous sinuses, or abnormal ones, which means that they develop venous collaterals. When they develop venous collaterals don't obey the normal autonomic regulation. That means if my oxygenation level goes down and my carbon dioxide goes up, the vessels dilate. And when they dilate, all the blood pressure goes up so that you keep the cerebral hemispheres oxygenated, right? Well, it turns out that collaterals don't do that. So if they have obstructive sleep apnea, they get raised intracranial venous pressure, which goes to raised intracranial pressure. And if they have an anomalous optic sheath, they have no disc swelling, which means they're getting more damage, or they get a chronic swollen disc. Now, what's really interesting is that if your blood pressure is not responding to autonomic regulation because you don't have it, then you get hypoxia. You get cerebral hypoperfusion. That means your brain is not getting oxygenated. So when we look at the VEPs, we looked back, we went, wait a minute, the VEPs aren't measuring necessarily raised intracranial pressure. They are probably measuring cerebral hypoperfusion. perfusion, and hypoxia. So people say to me, oh, VEPs measure raised intracranial pressure. I go, no, they don't. They measure whether your visual pathway from your eyeball to your visual cortex, your brain, is intact. And if it's deteriorating, something is going on. Something is going on to cause that. And you need to look at their sleep studies, you need to look at their intracranial pressure, and you need to do neuroimaging. So what we found was that craniocerebral disproportion was in fact a very small reason for the raised intracranial pressure. And hydrocephalus was just almost as important, because when you look at children with Apert syndrome, their volume of their skull actually increases, doesn't decrease. So this idea of craniocerebral disproportion and looking for optic nerve swelling, it's something that we need to move away from. So what we did was we put this surveillance protocol in at Great Ormond Street, and we applied it, and we re-looked at syndromic synostosis patients and compared it to the study that we published in 2003. And to cut a long story short, we had 60 patients, 25 of which were syndromic, so we concentrated on them. And what we found was the distribution of the syndromes was pretty similar. In fact, interestingly enough, we had more Cruzon patients and less Pfeiffer patients in the second study. But what we found was this, that the vision in the better seeing eye was now worse than 0.3, which is 20/40, in only 19%. We went down from 40% to 19%. And the reason was that we were helping direct the craniofacial surgeons to surgery sometimes sooner than they may have done in the past. So this is what I would say. I would say, just like my previous speaker said very eloquently, not everybody has the capability to do visual evoked potentials, which is why they haven't taken off in the United States, but are done in at least 3 centers in the United Kingdom. Here at Children's Hospital of Pittsburgh, we recruited Richard Hagan, who was one of the original authors on the papers I showed you, and we want to develop a network of collaborators across the country so that we can roll out the same type of testing that we're doing, so that children with craniosynostosis are getting the same kind of surveillance that we're able to give them here at Children's Hospital of Pittsburgh, Great Ormond Street Hospital Children, Oxford, and Alderhay Children's in Liverpool. So to that end, if you want to reach out to me, I would be more than happy to help set up this collaboration. And what I would really like to do is have a meeting wherever you like. We can have it in Pittsburgh, we can have it in Seattle, where people interested in doing visual electrophysiology in these amazing kids can get together and work out a protocol that can be done in the majority of sites that want to do it. Thank you so much for listening to me.
Thank you. So we have a few minutes for questions, if anybody has any questions.
Have I stopped sharing or am I still sharing?
Oh, you're still sharing.
Okay. It's always the problem, isn't it? Let's see.
Maybe
okay.
AV can just take over for you.
Yeah, maybe somebody can take over for me. I'll close everything.
Dr. Nishal, I was just curious, so for the collaboration again piece, like, are you looking just to like connect with the different centers? Oh, sorry, I'll let Dr. Taub take after this, but just curious, like what you envision as that collaboration, like just like talking to the centers, is that kind of?
No, I think the only way you can do this, so what we've done is we've developed a system now where people can remote in and watch us doing the recordings, so they get an idea of how we're doing the recordings, because that's really the crux of the issue is, you know, I showed you a very sensible, cooperative child. Most kids with craniosynostosis who are, and we're doing the young ones, they're not always cooperative. So there's a whole routine and that we have 2 people who are attracting their attention, we have 1 recording, and so we want to share that and how we do it. And we have a system where we use Teams, where people can remote in and look at the whole room and see what we're doing. And we also have a camera on top of the big screen, and we're working actually with Carnegie Mellon at the moment, where acquisition of data will only occur when the child is looking where they're supposed to be looking, because that's one of the big problems. We have the camera, so the person acquiring the data can see that the child is looking where they're supposed to be looking.
Yeah, and so okay, so you kind of, so the way that you've been doing it with other centers is just you kind of train them. Is that kind of where you train them on how to do it? But what about as far as equipment and things like how?
So it's really interesting. The equipment that I've shown you is pretty standard. So one of the problems is that a lot of electrophysiology units around the country at academic centers are research based. So when you ask them to do a clinical delivery, the clinical delivery demand goes up very quickly. So it's a question of we've trained ophthalmic techs to do the acquisition, and then we have the PhD or the visual scientist to do the reading. But you've just got to get your techs to the point where they're recording reliably. And so that takes a little bit of training, but it's doable.
Yeah, totally. Yeah. Yeah, thank you for that.
We have about 2 more minutes left if anybody has any other questions.
I'll ask about parental buy-in. You always have, parents are always, interested in going that extra route, because sometimes you find that they may not be, but I guess it sounds like you do have parental buy-in for most of this stuff.
We do. So when I moved here, Peter, from the United States, my biggest shock was the medical insurance system. And
that was my other question. Yeah, getting somebody to cover all this.
Right. So initially, they said to me, the commercial payers, well, this is experimental. And then when I gave them the body of work that had been done over 20 years, thankfully, CMS stepped in and said, no, it's not experimental. And so I won't say we get the full payment from Medicaid, but we get, what we normally get from Medicaid for this. And then the commercial payers have really improved. So we've done the groundwork I've been here 12 years. And I would say the first 3 years were painful. One of the problems, which is like what Dr. Dahl was saying, is, if you're doing something that you're showing works, but not everybody has that skill set, people sometimes can be apprehensive about doing it. But we really, really think that we've rolled this out in different parts of Europe. When I was at Great Ormond Street, and it's doable. We have the template. We know how to do it, and I'd love to try and set up a network of centers where if the local team can't do it, it's within a 3 or 4 hour drive where they can go to try and get it done.
Yeah, I love that. I will be reaching out to you, Dr. Nishal, after this.
I look forward to it. Thank you.
Thank you so much. Susan, if you're ready.
Yep, I'm ready. Let me see if I can share. All right, can everybody see that?
Yep.
All right, great. So thank you for having me. First of all, I am Susan Mach-Perrine, and I am really excited to be here to talk to you through the Born a Hero conference, because the mission of Born a Hero is near and dear to my heart. I'm not only a researcher, but I'm a mom. And one of my 3 children was born with a rare condition, which we didn't actually find out about until she was a teenager. So that's very unusual, but it did happen. But the research I want to talk to you about today is about a preclinical trial of a potential non-surgical craniosynostosis treatment. So I want to give these acknowledgments right up front so that we all know there were a lot of people that worked on this, first of all. And one of the things, of course, whenever you talk about non-surgical treatments, right, a lot of times there's a drug involved. And in this instance, it's infigratinib, and that was provided to us by QED Therapeutics, a BridgeBio company. Infigratinib has not been approved by the FDA or any regulatory authority for the uses discussed, as its efficacy and safety have not been established. And I am specifically talking about a preclinical trial in mice, okay? So first of all, why am I talking about non-surgical craniosynostosis treatment? We've already heard from a lot of other people that so many children have to go through multiple surgeries. And obviously the goal of this is to reduce the amount of surgeries a child has to go through and hopefully still get a really good response. So I'm going to talk a little bit about this non-surgical intervention, the results of this preclinical trial, and what we've concluded so far. And we still have more to do as well. So FGF and their associated FGFR receptors are key regulators of skeletal development, with many of these key regulatory systems shared between humans and animals, including mice. And mice were our model for our research that I'm going to share with you today. There are many, many FGFR variants associated with multiple craniosynostosis syndromes. And for our research, we chose the FGFR2C C342Y Cruzon syndrome mouse to explore efficacy of a potential non-surgical pharmacological craniosynostosis treatment. Non-surgical interventions are being explored, as most currently available treatments for craniosynostosis syndromes involve some invasive surgical procedures, which are not only painful and expensive, but may also require a great deal of post-surgical therapies and home care. And there's a great impact on the families, as some other folks have also discussed. Pharmacological antagonism of the FGFR signaling pathway is an attractive avenue of non-surgical intervention. And infigratinib, which is a selective FGFR1 to 3 tyrosine kinase inhibitor, and may be an effective therapeutic agent for the reduction of premature suture closure and other sequelae of FGFR activation. So right now, what do we know? We know that infigratinib treatment improves long bone growth in mouse models of achondroplasia and also hypochondroplasia, and it is being evaluated in clinical trials for children with achondroplasia. And again, infigratinib hasn't been approved by the FDA or any regulatory authority for the uses we're discussing, as its efficacy and safety have not been established. So the purpose of our study was to determine the in vivo efficacy of infigratinib in reducing the severity of craniosynostosis phenotypes in the Cruzon syndrome mouse model. This model has progressive postnatal fusion of the coronal and other sutures. Infigratinib was provided to us by QED Therapeutics, a BridgeBio company. And infigratinib, again, is currently specifically used in this preclinical trial. So let me tell you how we went about even looking at this in mice, because some of you are probably thinking, okay, what do mice have to do with children, right? So this is preclinical. The mouse model that we are using exhibits a known phenotype, which has some of the similar aspects of what is expected to be seen in an individual with Cruzon syndrome. So briefly, we used 40 specimens of the FGFR2C C342Y mouse model of Cruzon syndrome, which was previously used for several of our other research projects, if you want to check into that. But we split these 40 specimens into 4 treatment groups. So in the first group, we had 10 unaffected or wild type individuals that were treated with vehicle only. The vehicle is the solution in which the drug is dissolved and given to the specimens. Then we had 3 other groups which carried the variant causative for Cruzon syndrome in humans and produced this Cruzon phenotype in the mice. So in the first group, we had 10 affected or cruise-on littermates that were treated with vehicle. In the third group, we had 10 specimens that were treated with 0.5 milligrams per kilogram of infigratinib in the vehicle. And then we had a fourth group in which the specimens were treated with 2.0 milligrams per kilogram of infigratinib in vehicle. And again, there were 10 of those. Now, within each one of these groups, there were 5 females and 5 males. Something just happened, so hopefully you can still see my screen. Okay, my computer just glitched for a second, so hopefully everything's still fine.
Your screen. There, actually,
excellent. Thank you. I was like,
you.
oh no, did everything go black for you? Because it did for me. So anyway, the mice were treated.
Hold on one second. We can't see your slides. So if AV could help us with that. We have Susan's slides on file. Give us 1 second.
I could also try to share again.
Yeah, you want to try?
Actually, it'd be better for Susan to share.
Yeah, I'll go ahead and share them again.
Thank you, sir.
Okay. Can you see that?
You're good now.
Okay, great. I was like, everything just went black for a moment. So hopefully
it looks good now.
Okay. There we go. All right. So these specimens were treated once daily with a subcutaneous injection of whatever their treatment was. And then at P16, the specimens were euthanized and actually sent from the Icahn School of Medicine at Mount Sinai, which is where the specimens were raised and treated, to Penn State, which is where we performed microcomputed tomography. And we specifically wanted to detect bone. We wanted to look at the skulls of these mice to see if there was any effect on shape and also any effect on suture fusion. So those were the parameters then that we assessed: suture fusion and morphology of the cranial vault. So these 40 specimens were split into the 4 groups. And here we have visualized 3D volume renderings of representative skulls for each group. I'm going to start off actually with a left lateral view of a wild type or unaffected specimen in the top left. And on the right-hand side is a cruise-on or affected specimen, which was treated with vehicle only to give us an idea of affected baseline. The wild type provides our control baseline, and the one on the right, which was treated with vehicle only, is our affected baseline. So then we have our 2 treatment groups. So on the bottom left, I have a representative specimen that was treated with 0.5 milligrams per kilogram of infigratinib each day. And then the 4th panel has a cruise-on specimen, which was treated with 2.0 milligrams per kilogram of infigratinib per day. So I'm just going to spin these skulls one time so you can kind of have a quick look. If anybody is interested in seeing this in more detail, just let me know. But pretty much this 3D visualization of the skulls is the first step to allow us to appreciate differences between overall head shape within the groups. But then, of course, we need to measure them. Was there actually any effect of treatment? So today we're going to focus on the cranial vault. And I have just outlined that for you. It contains multiple bones and the coronal suture, which normally fuses in individuals with cruise-on syndrome. The coronal suture is the fibrous joint between the frontal and parietal bones. And the skulls in these images are all facing left. There is a human skull here in this image on the top left with a mouse skull above it. So these are P16 wild type or unaffected skulls treated with vehicle. The cruise-on syndrome is characterized by synostosis or fusion of the coronal suture, which I've outlined in red here, and other sutures of the cranial vault, facial skeleton, palate, and cranial base may also be involved, but we're just going to focus on the coronal suture for today. So let me explain what we mean by coronal suture fusion. Any measure of fusion is limited by whatever imaging method we use. And the scans for these specimens were acquired at 13 microns or 1,000th, excuse me, of a millimeter. So I can reliably see structures that are about 30 microns in size at this resolution. So to put it into perspective, I like to explain it as 1 millimeter is about the size of a sharp pencil point or the tip of a sewing needle. And our images are at a higher resolution than that. So at P16, all wild type specimens displayed a partially fused pattern of suture fusion. This means I could clearly see the line of the suture, but more than 10% of the slices along the coronal suture between the frontal and parietal bones looked as though they were actually joined together. So many of the Cruzon mutants treated with vehicle only actually had, refer to the right-hand side here, a completely fused coronal suture. So on the right-hand side, this is the fused side. I can't even really see where that suture line is. And if I look at individual slices, I really can't find the suture. It looks like it's just one bone between the frontal and parietal bone. However, there are also situations in which we have a very patent or open suture, such as on the left-hand side of the screen here. And this could be seen sometimes also in instances of hydrocephaly, for example. So I took measurements on 25 different skull sutures, but I'm going to focus on the coronal suture. And the first thing we wanted to know was if treatment with infigratinib affected suture fusion. So we measured the coronal suture fusion in bone CTs of these 40 mice that we used in the experiment. And the goal was for treated specimens to show equivalent scores to that of the wild type or unaffected specimens, which are baseline for typical development. The groups are listed across the bottom of this, this graph, and the left coronal suture is shown in gray and the right coronal suture is shown in pink. The mean fusion score for each group is shown against the vertical y-axis with standard error bars. And a suture fusion score of 1 or below is completely patent or open, and larger numbers indicate increased suture fusion with a score of 3 or more indicating that the suture was completely fused or obliterated. So the take-home message here from this graph is that Cruzon treated with 2.0 milligrams per kilogram of infigratinib have coronal suture scores that are equivalent to that of the wild type controls treated with vehicle. The asterisks, which are shown above at the top, indicate differences found between groups. So Cruzon treated with vehicle and Cruzon treated with 0.5 milligrams per kilogram of infigratinib are both significantly different from the wild type groups, but the 2.0 milligram per kilogram treated specimens had the same amount of suture fusion as the wild type individuals. The next thing we wanted to do was look at the morphology of the cranial vault. So what we did was take 15 anatomical landmarks which describe the primary axes of the cranial vault. I specifically used Malpaca, which is a landmarking module within 3D Slicer. If you're interested in landmarking or that type of thing, please feel free to reach out. I'm happy to talk to you about it. And then we started to do some actual statistical analyses to find out what was going on. So we used the 3D coordinates of these 15 anatomical landmarks, which represented the cranial vault, and also included the area of the coronal sutures, and we analyzed it by principal components analysis, or PCA. So this plot is a PCA plot, and basically each dot in this scatter plot represents an individual, okay? So as shown by the plot legend on the right, the wild type or typically developing unaffected specimens are shown in black, and they all plot together very tightly. There's a little ring around them showing a 90% confidence interval where 90% of those specimens are expected to fall. And they fall primarily on the far left end of PC1 and about the middle of PC2. And this is what we expect those specimens to look like, okay? So the next thing that we were looking at was, what about these individuals at the far end of the plot? Well, those specimens are actually Cruzon that were treated with vehicle only. So they are the baseline for affected individuals without any of the drug treatment. And so these specimens have a much more rounded skull. You can tell it's a very different phenotype from these wild type individuals. So also then we have a group of specimens that are sort of starting to go towards the top of the graph, especially on the y-axis or PC2. And a lot of these specimens are plotting in red, which were the 2.0 milligram per kilogram infigratinib treatment group. And those mice are starting to overlap with the wild type group. And we also have a fourth group, which is the 0.5 milligram per kilogram infigratinib group. And they're just sort of out here in between the Cruzon with vehicle and the Cruzon treated with 2.0 milligrams per kilogram of the drug. The overall conclusion of this slide is that the mice that were treated with 2 milligrams per kilogram of infigratinib are probably more similar morphologically to the wild type due to the amount of overlap of their confidence ellipses shown here. Okay, but that doesn't give us a ton of information. It's not all inclusive. This is more exploratory, okay? So we want to know, what are the specific differences? Were there any changes in widths or heights or lengths? And yes, there were. The first thing that we did was, in order to define the differences among the groups, we performed Euclidean distance matrix analysis of these 15 landmarks defining the cranial vault. So EDMA allows us to localize differences to pinpoint the most severely affected areas. And this analysis that I have up on the screen right now compared the wild type treated with vehicle only and the Cruzon specimens treated with vehicle only to establish baseline differences between wild type and the Cruzon specimens. So a small number of representative linear distances are shown on a Cruzon treated with vehicle male here in these images, and the majority of the statistically significant linear distances were between 6 and 14% different. So if you see a line here between where two anatomical landmarks would be that is in pink, that means that this distance is statistically significantly shorter in a Cruzon mouse treated with vehicle as compared to an unaffected littermate treated with vehicle. If it's a blue line, that means that it's longer in the Cruzon specimen as compared to an unaffected littermate. So the pattern of differences between wild type and Cruzon, which were both treated with vehicle, is established by that first analysis. Most of the linear distances shown were between 6 and 14%. So the next thing we looked at were the wild type compared to the specimens that were treated with 0.5 milligrams per kilogram of infigratinib. Now here, there are still some very similar statistically significant linear distances, but the magnitude of these statistically significant linear distances is smaller. Most of those linear distances were only different from between 5 to 9%. So it was approaching a more usual or typical development. Whenever we compare the wild type with vehicle and the Cruzon that had been treated with 2.0 milligrams per kilogram of infigratinib, we found that there were still statistically significant linear distances, but that most of these statistically significant linear distances are only about 5% different from wild type and vehicle. So there was definitely an improvement in approaching the more typical distances that were expected. So overall, our conclusions from this project is that these statistical analyses indicate treatment affects head shape. The treated cruson specimens had overall skull morphology more similar to wild type than those treated with vehicle only. The treatment of postnatal cruson syndrome mice with infigratinib affects patterns of coronal suture fusion. Patterns of coronal suture fusion or patency become more typical with increased dosage of infigratinib. This is our research team, or at least as many as I could get photos of. And I really want to thank them because there were a lot of people involved in this preclinical trial. It wasn't huge by any means, but many, many people were involved in this research, and I'd like to thank them all. They came from Penn State, the Icahn School of Medicine at Mount Sinai, Mayo Clinic, and of course, those at QED Therapeutics. So at this time, if I have any time left, I would be happy to field any questions.
Yes, we do have plenty of time left. So if you want to put them in the chat or unmute yourself, you're welcome to ask any questions.
So let me stop sharing my slides, first of all. Did it go away?
Yes.
Okay.
You are good.
Great. So I see a comment from Carolina Sommer, which says, Ellen and I are chatting about how exciting this is, and thank you so much. So yeah, this is exciting. I have to emphasize, because I know there are so many parents here, I have to emphasize that this is preclinical. So this is in mice. We are not ready to test this in children at this point. There are other studies that need to be done. Based upon findings in some of the other studies with this particular drug, I actually have more questions now. So we want to explore some more things. We don't want, you know, anything to be put out there before it's ready, but I think this is very promising. That is my personal opinion, that this is really promising work, and I hope we're able to pursue it further. So was I able to look at the skull base? Yes. Yes, I did look at the skull base, and there are changes in the skull base. I also looked at the facial skeleton. There are changes in the facial skeleton. There are changes in the mandible as well. So basically, if you're familiar with any of Joan Rischmeier's previous work with Cruzon syndrome, Apert syndrome, Pfeiffer monkey, any of that, I've worked with her for the last 13 years, and very recently she retired in 2023. So Kazuhiko Kawasaki and myself have taken over as PIs in what was formerly the Rischmeier lab. We still call it the Rischmeier lab, and Joan still pops into lab meeting and things. Sometimes it's wonderful. But, you know, we're going to continue pushing forward with some of this craniosynostosis research because it's very exciting.
Susan, can you talk about timing a little bit? I don't think you didn't vary the times when you know, you mentioned mice mouse, but you didn't say, you know, you didn't tell us when they were getting it. And I think the other word that came up was litter. So I assume that they were young pups.
Yeah, let me tell you about that then. So the timing of the treatment and the ages. So the mice are born at P0. That's just what we use for newborn. Okay, so that's the day of birth. So at P2, or the second day postnatally, those mice received a daily injection until P16, or 16 days post-birth. Okay, at 16 days, we collected the specimens. So those mice then were 2 weeks, 2 days old. And that is, I guess, comparable to kind of a preteen getting on towards puberty child. Okay, so that's when they were collected. The mice were treated every day. And does that answer your question? Was there more to it?
Yeah, no. It just, but like you said, it raises other questions. You know, is the earlier you give it probably better? And my assumption would be yes. The later you wait, the less effective the medication would be, which then brings up a whole host of questions about the feasibility of giving this drug prenatally or antenatally,
Right.
to sort of get the ball rolling earlier.
Absolutely. That is actually something I'm extremely interested in, and most of the currently funded research we have is actually in prenatal development. None of it is currently with QED, but we are looking to continue this line of research with them. A lot of our research has been in prenatal development, and I think that's an excellent place to actually continue some of this research, and not just on the pups, but also on the mothers, whether there's any impact on the mothers. Yeah, like you said, it opens a whole new venue of questions. I see I have another question from someone. So did you have a chance to check downstream signaling pathway like ERK1 and 2, etc.? So we did not in these particular specimens. We did look at some ERK1, 2 signaling in the past in some of our manuscripts, but we just haven't got there with this particular line of research. But it may be happening in the near future.
All right, I think it's time to wrap things up. If you guys have any other questions, feel free to put them in the chat, and we will hand it over to Marcella. Thank you so much.
Thank you.
It's a pleasure to be here. It's a pleasure to be able to talk about my country. It's a challenge. I want you to know this is very difficult for me because it's not only not my first language, and I'm not used to speaking English, but I'll do my best, and feel free to laugh at me and to help me if I'm blocked in any moment, okay? And of course, it's not an easy task to speak about a country, a beautiful country, as it is Colombia. I was wondering if I was like more talking about as a craniofacial surgeon or a Colombian, and I tried to do both of them. So I hope you enjoy this part of a Colombian craniofacial in this beautiful presentation and meeting you've been having today. So Colombia is definitely a land of extremes, and this is going to be the word of my speech, extremes. Geographically, we are extremely different. We are crossed by a mountain range called the Andean mountain range. So we have snow-covered mountains and beaches, tropical beaches, because we are surrounded by the Pacific and Atlantic Oceans. We have desert zones called Los Llanos Orientales, and we have a little bit of the tropical Amazon rainforest, So that makes us very different, not only in altitudes and climates, but only in cultures, biodiversity, and social, cultural situations. This gives us a very, very significant situation in many aspects. And obviously, today we're going to talk more about the social and health conditions to be focused in our craniofacial patients, but everything is going to be a part of what we're going to mention today. There are people in the farthest places of the country that need to cross very big rivers or cross very high mountains or even canyons to get access to good health services. So even though up till now we have good coverage with health coverage and very good places to treat patients as doctors and very good medical systems, it is very difficult for many people to get in touch with us doctors or health workers. This is what I like to show most about Colombia, our biodiversity. We're the first country with birds or different type of birds. We have a very beautiful flower that's very important. There are orchids, but most of all, I want you to know that people is that even though we have social and economic difficult conditions and we have poverty situations that has which is suffered by most of the population, people is really happy. We are characterized and recognized internationally by being happy people. So This is a image to remember you, that saying that when life gives you lemons, make lemonade, because I think that's a saying that really characterizes Colombia. You can find here people that lives daily in very difficult socioeconomical conditions. They wake up even though they're not sick, not having what to eat or what to do, but they start the day with a big laugh, with the best of the attitudes, and they do the best of lemonades. And that's what we're finding with our syndromic craniosynostosis patients, and that's what we're doing to be able to have craniofacial groups, even though we have lots of barriers, and that's what we're going to talk about today. Those are our Colombians with syndromic craniosynostosis. This is a mother with a daughter. She never knew what she had until she went to the hospital with her daughter. So yes, very late diagnosis. If you in the United States have those late diagnoses, we do have them too. And yes, we have those barriers in detection and diagnosis, and worsened by all of these characteristics, social, demographical, geographical, that I've mentioned before. Barriers in diagnosis, not only because, as I've said, there are many difficulties for some of the patients to arrive to the central cities that are the one who have more possibilities to offer health services to the patients, but also because there's lots of ignorance or not knowing and knowing of these diseases, as I've heard you mentioned too in many other speeches, those wonderful speeches I've been hearing today. Here, people do not know not only what these diseases are, but that there are many things that can be done at that, and then here in Colombia, we are not only doing them, but achieving very good results. In remission or getting the patients into these multidisciplinarity craniofacial centers, it is very difficult for us to, even though when we go to a place where we ourselves as craniofacial doctors do the diagnosis, then it's very difficult to get the patient into our clinics. In timely opportunity, in timely treatments, to be able to prevent many complications. I was hearing the previous speeches and seeing how timely or promptly treating those patients prevents the using of tracheostomy, as Dr. Dial said, or what Dr. Nishal said with the visual alterations. When you have the opportunity of treating these patients early, there are many preventions of the terrible alterations, and you have less requirement of surgeries or number of surgeries. You need less number of surgeries. Of course, we do not have these research groups. We do not have groups that invest in investigations. We do not have fundings for genetic studies, and it is very difficult for us to do long-time follow-ups or be able to give continuity to our treatments. This is a map. This is a Colombian map, which I brought to show you that in the center are the cities that are the most developed cities. This made me remember I studied in a British school. This was the last time I was able to speak and study English. But my teachers came from Great Britain, and they thought they were going to find us living in trees. But no, the ones that live in those conditions are the ones that live in the darker zones in that map. We do have well-developed cities in the center of the country, and yes, we have three main countries that are Cali, Bogota, and Medellin, and we have very good craniofacial center over there and we're having very good results with the patients treated over there. But those other places, are having difficulties because they have no good routes to be able to be transported to the center of the country. Some of them have difficulty with public services. They are exposed to malnutrition and very difficult general life conditions. So even though we get to do some surgeries for those kind of patients, or even though we do the timely treatment, or we do get the opportunity to make the surgeries, sometimes the post-ops are not that easy. These are some pictures I found of people in Chocó and La Guajira. Those are very, very poor zones, people that have no access sometimes to water or electricity, in places where we can find children exposed to severe malnutrition. What not only government, but some private foundations do is that we go and visit those groups of families and people to help them with their health situations, but it's not enough. You can go and make a diagnosis, but you cannot assure long-term conditions. You can bring those children sometimes and make some treatments, but it's not the same as being able to take them to your country. Besides, I wanted to mention that some make barriers higher. I've worked for Operation Smile since many years ago, and this is an Indian family from Riohacha, from La Guajira, and I say they make barrier higher because here we have ethnicity barriers. These Indian mothers sometimes have to run away with no food, even though I've seen them with no shoes, because culturally they think that when their children are born with, these cases are with cleft lip and palate, that are the ones that we can really do surgery to in these trips. But of course, with any other syndromes or craniofacial syndromes that happens to, they think that they do not have, that they were not born to live, or that do not have the right to live. So moms, desperate to preserve their lives, have to run away and run. They do not even speak Spanish, and they have to run away from their real cultures and situations and try to search for help in the closest places they can get to. So you do the surgery, but then they have to look for help to restart lives. As these people cannot get promptly or early enough to attentions, then you can find really advanced and complicated cases when you go visit these distant zones. To speak about barriers in diagnosis, I found these images. This is a study published by Colombians. We do have very good access to images. This is an image of a polysynostotic craniosynostosis diagnosed prenatally. And he also made pictures of the craniosynostosis with the 3D images, but there's few people that can be that can achieve to have these type of images, or to have or to receive, or the mothers to receive these kind of images, to be well, to have, first of all, to have prenatal controls, or second, to be able to have these kind of images done. So what is it what we find? Not only not any of these images, but many times not any prenatal controls at all. The other things is we do not have enough geneticists in our country. I looked at the Genetist Society, and we have in total 150 genetists for the whole country. When the patient finally gets, we as a multidisciplinary study send them to the genetists, but when they finally get to go to an appointment, they ask for studies and they're not done here. So when they can afford them, because not always the health policies cover them, they are not taken here, or then they are not done here in Colombia. Our prevalence and incidence is still or we are based on the national prevalence and incidence. I would say, for what I've seen, we have an important incidence inside our country, but we have local sub-registration and not enough reports. We have premature and newborn undocumented deaths. We have people that did not get into our cities, and beside those ethnicity ideas of not showing or not getting those patients into attention, make those local sub-registrations worse. Besides the barriers in remission, I've already mentioned the unknowing, or I would call it ignorance, of many of the health workers around these diseases. They're uncommon, that we should know that there's people here trained to treatment, and that there are multidisciplinary groups trained and well trained to give good results and opportunities for these type of patients. And the other slide is, I think, worse, and is when the health insurances or the insurance companies think that they can save money paying to a place where they are where the surgery can be done for less money. So definitely that's a very bad idea, and that's a very expensive idea, and that's the worst scenario for the patients and their families, and of course for the whole social for the whole social condition. So the company thinks that if I send them to a hospital where there's no craniofacial team, it's going to be cheaper because they're not going to do the total surgeries that they are proposing when the multidisciplinary group is working, and they are attending the patient with psychologists, social workers, the whole of the therapies needed for the patients. And at the end, the child ends up with lots of more surgeries than would have been done if he would be sent to the multidisciplinary center. This is my partner. This is Dr. Diego Caicedo. He was the one who started the dream of making a craniofacial center here in Cali. When I came to Cali, when I ended my preparation, he was here with many of the work done, and I have the pleasure to work with him. This is part of our multidisciplinary team. This is, yes, as you've said before, not only this I've mentioned, this is just some pictures to say all of us are important. As you've mentioned before, I would love to have a psychologist group as the Oxford team, but we don't, because here in Colombia, unfortunately, psychologists are not covered in the health insurance politics. So unfortunately, we do not have that great support in our group. And this is the support odontologists or dentists give us with the maxillary orthopedics. Sometimes we have barriers for the solutions. What happened when we have the multidisciplinary center? We can have if we have a prenatal diagnosis with the images I show you, we can have the patient sent to a multidisciplinary center, have the genetic studies, the ones we can do here in Colombia. Sometimes we can be ready to do program C-sections and attend a newborn with or be prepared to give specific attentions to the newborns, and be prepared to attend not only the babies but the whole family to work around the whole situation. When you are able to attend many patients with the same characteristics and situations, you can give them better opportunities and results. And that's the key point of working in groups and multidisciplinary centers. I've already talked about opportunity or the adequate time, but the other thing is these are long surgeries. We sometimes take 6 or 8 hours in a surgery like a monoblock like this. We need expensive materials. We use expensive materials. But definitely this changes the life and the functional outcomes of a patient. This is a pre-picture and the post-op pictures. This is the CT image of that picture with the monoblock osteotomies and the internal distractors for that patient. And this is the pre and post-op picture of that. We've heard about all other pathologies that can be well addressed if we do them in an early way. The early decompression of the hypertension will prevent or diminish visual and developmental or neurodevelopmental losses. The prevention of unneeded tracheostomies or gastrostomies, of course, when there are no other alterations associated, as we've seen with Dr. Dahl. The protection of the eyes. We should not find mature adult patients with this kind of proptosis untreated. The changes we've been speaking, severe hypertension changes. So we can manage or do early posterior decompressions, as we've heard in the previous pitch, with the using of interior distractors and with very significant changes that definitely diminishes the number of surgeries and the number of associated alterations that can make life better for the child and for the whole family. Pre and post operation, pre and post views of how the not only aesthetics but the functional situations in general can change with this type of surgeries. Previews, this boy needed an external distractor. This seems very difficult for the patient, but when you have such a severe proptosis and this patient had a very severe alteration, airway alteration, this had to be advanced with this kind of distractor, and it definitely changed his life. Same as I said, not only in the aesthetic aspects, but in the functional aspects. These are some twins with the different phenotypical presentation of the alteration. One needed the tracheostomy and the other one not. This is one of the twins that, even though we first tried to do a monoblock with an internal distractor, then we needed to do a second time with an external distractor, because still the functional alterations of the proptosis was so severe that it was not enough. So even though when we can get over all of these barriers I've mentioned, it is still very difficult and it still needs lots of surgeries, even though when we try to get the best of these multidisciplinary centers. So there are so many difficulties within these diseases that you all know that making things more or making things more difficult is really hard. This is the one that had the most severe presentation of the disease. She also needed the internal and external distraction, and she hadn't been able to we haven't been able to offer her she's still with the tracheostomy and with severe alterations of her face and her aesthetics and her functional situations. I've mentioned difficulties for long-term follow-ups. Of course, not only for us, but for the whole multidisciplinary treatment group. I was mentioning, I would dream to have a support group at this as the psychologist. But this should be a must. What do you do in the Oxford? I was taking pictures of the slides they show of what they do to keep on dreaming of having one day support covered by the health insurances and companies. Sometimes we get these kind of older patients, skeletally mature, but we also need to give them opportunities, even though it's more difficult. And they also get better, and they can get better. Difficulties for investigation, publishing, and sharing results. This is Dr. Caicedo and me at the Congress in Seattle, at the meeting at Seattle, where we had the honor and pleasure to meet Carolina. And when she told me she wanted us to come, it is really difficult for us to get posters. This is all done by us. We never have groups of investigation. Even though we're both teachers of the university, we do not have anything or any support for these kind of activities. It must be us. It's us, after finishing the surgeries, the ones who have to write and organize the data. So in conclusion, yes, as a country, we do have unique, extreme social, cultural, and geographical conditions that have made under registration of our cases. We know and value the need of multidisciplinary group support, but it's not easy, and people put barriers to the barriers. And we need the health companies to understand that higher initial investments mean lower total costs and better results in socioeconomical outcomes. Again, sorry for my English, and I really did try to make myself as clear as possible. Thank you for your invitation.
I thought you were very clear. You did a great job, so thank you. We still have some time for questions, so feel free to put them in the chat or unmute yourself. And thank you again, Marcel.
You know, in some of the, so as far as like, I was just thinking like a cost, like you say, you know, like there's like the distance and the mountains and those barriers, and then there's the poverty. How, like once they do get in, how do you cover those costs? You know, like if they can go to the city to even get a treatment, like how is it? I mean, like they don't have.
We
I mean,
do
I'm
have a
assuming they
good
don't have.
health insurance coverage, and yes, they do have to cover them. We have to like get the company to understand the importance of the surgery, and to get the people or the doctors or the, I don't know, you say auditores, to understand that I was saying that what I was saying, that the first surgery or that one initial surgery and timely surgery is a very good investment, we should call it that way, for a better outcome and a better life for the patient. I am sorry to put it in that terms, but that's the way they like to hear about it, and that's the way we present them to convince them, so they cover us. It's like it's us mediating with the social companies. So that's a job we do too.
So you have to do like some of everything, I guess. Sorry, Diana has a question. It seems like Dr. Tab.
Yes, you know, I'm a craniofacial researcher myself at UCLA, and I'm not a surgeon. And so I had questions about with the distractors, are any treatments, any topical treatments ever added, you know, other than anything that helps with anesthetics for the surgeries?
Topical?
Like, for example, maybe to inhibit, I don't know, to inhibit fusion, or to allow for bone to grow, or is there any like topical treatments that are ever added? And if so, is the underlying meninges ever a subject for treatment?
Yeah, and we're adhering to the clinical guidelines that are being used worldwide. We're doing exactly what is done by all of the craniofacial centers. Is that I didn't like stop to talk about those because I was trying to give you like an idea of our Colombian situation, to focus on what I was like invited to say. But yes, we're doing everything that's being done in the rest of the craniofacial centers in the world. Everything. The only thing we do not we're not able to do is the whole genetics studies, because we do not have them, and as they're not done here, the only people that can do them is the people that can afford them. They send the no sé, the labs to the United States or wherever they can take them, but not everyone can afford them. And studies with mice, studies with, we do not have groups of researchers, but in treatment, we have everything that's done in the rest of the world. In the United States, in the group of Holland, that's like the one that writes the clinical guides.
From coming from the US and stuff, and like, is there like, how do you envision like something that would be helpful coming from our end, I guess? Like, is there, like, you talked about all these barriers. I mean, is there something that you think would make it, like, I don't know, like, that we can do on our end, I guess? And like, is there
lots of things? Yes, I was hearing all of the speeches, and I was wondering, for example, all of you, there are lots of cases here. When we take our posters to the meetings, they said there are lots of cases. So this would be a very interesting place for the researchers to come and get, even though for data, for analysis. So if you want to do research and analyze, if there are risk factors here that make them more common. As I've said, we have under registration, but I do think that we have more cases than other places, as it happens in Mexico. For example, for cleft lip and palate, that we do have lots of cases. They've found that as we have lots of flower crops, mothers or women in the age of being pregnant, or the, ¿cómo se dice? In the age of pregnancy, are exposed to the chemicals of these flower crops and any other crops. You know that they're very common here in Colombia. Were exposed, and were those women presented more cases of cleft lip and palate. Mm-hmm. And we have lots of cleft lip and palate. So yes, you can have investments if you want to, or if you're interested, because yes, we have more cases here. I cannot assure it because we have under registration and we cannot do the research, that there are lots of things. If you, for example, have the interest in supporting families, I was hearing now, well, you speak English, but if there's people that speak Spanish, for example, you with families that can speak Spanish and can give support. We have many families that are searching for those chats and support of other families that have gone through and wanting to know what else can they do. Sometimes they sell everything to be able to go to another country to receive whatever they can. Sometimes there are things, for example, psychology or therapies that can be done via email. There are lots of things. People, for the speech therapies, many times we achieve the people to get in touch by the internet, and we help the people to get in touch by the internet with speech therapies to help them, for example, with the cleft lip and palate. It has been easier with, I'm talking about more cleft lip and palate because it has been easier because it's more common. So there are more things organized. But that gives me lots of ideas. There's lots of things to do here. Lots of things.
Yeah, and I was thinking, as far as like research, like, would you be the person to, like, if, some other researchers here or are like, is there a way to reach out to you to get some of those patients? You think they would participate in some of those studies from, just to get a better representation of?
It could be through me. Obviously, we would need someone to help me, or because I do not have the time to dedicate.
Is that something that can be done, like having that, getting some of your patients to participate in some of the, yeah, okay. Yeah, so I just want to say that was such a wonderful section, everybody. Thank Dr. Taub and just all the
The
speakers.
speakers were great.
Yeah, just so grateful, yeah, for all of you guys. And again, I just, from the bottom of my heart, just want to thank all you guys for all the work that you're doing and for taking a work day off your out of your day to be with us. Something that's really important to us. So just that says so much about you. And I just want to say thank you to our generous, kind, and supportive sponsors who we're so grateful for, because without them, we couldn't do this conference and do what we do. So from the bottom of my heart, again, thanks a million to QD Therapeutics, Pfizer, Tyra, Regeneron, and Seattle Children's Research Institute. Just so appreciate your support.